Hello guys, hi and greetings everyone. Welcome back. Can you hear me? Can you see me? Not a problem, right? Yes, Ankit, thank you for your confirmation. So we are going to start the session. Just hold on a couple of minutes. Okay. So let us start with today's sessions, by the way. Yeah, good evening, Dana. Hi. Welcome everyone. I think there are quite a few number of participants are there, so not an issue. So we'll go with the session by now. So if there's any problem with the audio visuals, you can tell. Otherwise, we can start the session. We are good to go. Okay. So I think last week we have discussed on the esophageal disorders. This week is all about discussing on certain intestinal disorders, especially like the main importance. What we are going to give today is on the diarrhea, maybe malabsorption. If there is time, we'll be discussing on IBD and IBS also. And I wanted to really teach on the colonic polyps and colon cancer also in a short nutshell, but I don't think there will be sufficient time for the day. But anyway, we'll be discussing eventually. So it's not something that's going to be incomplete, by the way. So let us start with diarrhea first. I mean, diarrhea is often a very underestimated topic, but still it has a major role to play in your exams. Especially you might get an occasional one question, so you don't want to miss it out. So let us start with that. So as far as diarrhea is concerned, so there are many different definitions for diarrhea, but the most important definition for diarrhea is the amount of stool, the absolute increase in the stool quantity. So that is what we really call it as diarrhea. So just passing more than 3 stools per day is not diarrhea, because there are some definitions which tell if you pass more than 3 stools per day, that is basically diarrhea, but this is not the case. So the number of stools, when it increases, it's really not called as diarrhea. If you want to call it as diarrhea, there should be an absolute increase in the stool quantity. Absolute increase in the stool quantity. So what is the normal stool quantity for that matter? So the normally stool should be approximately like less than 200 ml per day or less than 200 grams per day. So that is the normal quantity of the stool in an adult. So if you take an adult for that matters, if you pass more than 200 ml per day, so that is what we define as something called as a diarrhea. So, or probably if you talk about children, in children, it cannot be the absolute number because the children's body weight is less, and comparatively, like the body surface areas are different in children. So as far as children are concerned, if the amount of stool that is passed is more than 10 ml per kilogram per day, so then probably you can call it as a diarrhea. So what do you mean by diarrhea? The most important definitions of diarrhea include, the number one is the most important, absolute increase in the stool quantity. So that is going to be the most important. There are different terms for different things. For example, if the patient does not have absolute increase in the stool quantity, but they're passing multiple stools per day, like they're passing 15, 20 times, but every time they go, they pass only 5-10 ml of stool. That is not diarrhea. So even if they pass 15 times and every time they go, they pass only 10 ml of stool. So the absolute amount of stool that they pass per day is only 150 ml. So that doesn't come into the definition of diarrhea. So whenever there is an increase in stool frequency, rather than the increase in absolute quantity of stools, that will be referred to as something called as pseudo diarrhea. That's not a true diarrhea. So if you want to know about the true diarrhea, there should be an absolute increase in the stool quantity. So apart from that, there is another definition which books will give you, altered stool consistency. Once again, this is not the true definition of a true diarrhea, but still, because the books tell that, we can also write that altered stool consistency. In the sense, especially if they have more than 75% of water content. Usually the amount of water should be less than 75%. If there is more than 75% of water content, you can call it as diarrhea. That is due to altered stool consistency. But again, this is not the exact definition of diarrhea. Whenever you talk about the exact and true definition of a true diarrhea, that is an absolute increase in the stool quantity. Can you tell examples of a pseudo diarrhea where the amount of stool passed will be normal per day, but they pass more stools per day, like more frequency? So what do you think? So where is the pathology? And I mean, what is an example for this? It's a very common example. I'm asking about pseudo-diarrhea. So if anyone is listening to this, you can answer. I'm expecting some answers at least. So examples of a pseudo-diarrhea. Anyone? So I'm talking about the pseudo-diarrhea. Nobody's answering, by the way. So, okay, fine. So pseudo-diarrhea in the sense there will be increase in the stool frequency, but the absolute amount of stool passed is completely normal. The most important is your irritable bowel syndrome. Very common scenario. So IBS is a very common cause. Thank you, Mehak, for answering that. And second is hyperthyroid disorders, hyperthyroidism, primary or secondary, or whatever may be the case. Hyperthyroid disorders, that is again due to increased bowel motion rather than secretory or increased stool frequency. Or it could happen in the setting of some anorectal disorders like proctitis. I mean, for example, like patients like ulcerative colitis who have invariable proctitis, so they might end up in similar scenario like this. So, or after a fecal impaction, or by keeping a vaginal pessary, this will cause rectal obstruction. So in that setting, they'll pass small amount of stools because the rectum is impacted with stools, so that whatever remaining, they will pass like small amount, 10 ml, 15 ml, like for multiple times per day. So these are the usual reasons why we get this pseudo-diarrhea. But as far as exams are concerned, IBS and hyperthyroidism are very classic examples of a pseudo-diarrhea. I think I've told in my premium lectures itself about on hyperthyroidism. I told you it's not a true diarrhea that happens in hyperthyroidism. It's always pseudo-diarrhea. So hyperthyroidism never causes a true diarrhea, increase in the absolute amount of stools. It's only the increased frequency of stools that happens in hyperthyroidism. So anyway, fine. So we have completed the definitions of diarrhea. So based on, the duration of diarrhea, you can divide diarrhea into acute diarrhea. Probably second one is called as persistent diarrhea. I think this is something which you have studied in pediatrics itself because this is more relevant to pediatric patients rather than adults. But third one we called as something called as a chronic diarrhea. As far as acute diarrhea is concerned, typically is defined as something that is less than 14 days in duration. That's what we call as acute diarrhea. The most common reason, or invariably, most of the times acute diarrhea will be infectious in nature. There will be some infection. It could be dangerous or non-dangerous, but some infection is the reason for developing an acute diarrhea. So when you come to chronic diarrhea, and whenever diarrhea exceeds 30 days, more than a month, so that is what we define as a chronic diarrhea. So usually chronic diarrhea will be non-infectious. It's unlikely to be infectious, except for the fact that in immunocompromised hosts, like probably patients who are suffering from HIV, probably patients who are suffering from chronic immunosuppression due to transplanted states, or they're receiving chronic steroids. So except in those people who are having immunosuppression, chronic diarrhea can be due to infection like cryptosporidium or isospora. But in immunocompetent individuals, usual reason for chronic diarrhea is generally non-infectious. It could be either a malabsorptive disorder, or it could be some inflammatory condition like ulcerative colitis or Crohn's disease, IBD, or it could be some functional disorders like IBS. You have to think these kind of things. So chronic diarrhea is very unlikely to happen in an infection unless and until the patient is immunocompromised. So as far as persistent diarrhea is concerned, persistent diarrhea can be infectious or non-infectious, doesn't matter, but most often it will be non-infectious only. But nevertheless, so persistent diarrhea definition is something that lasts for 14 to 30 days. So this is what we call as a persistent diarrhea. So then coming to the classification of diarrhea based on pathophysiology. If you take the pathophysiology of diarrhea, you can divide the diarrhea into three. So one is called as a osmotic diarrhea. Second one, you know very well, that is called as a secretory diarrhea. And the third one, you get diarrhea due to altered motility, altered intestinal motility, even though it is not a true diarrhea. Increase in intestinal motility causing diarrhea-like appearance is actually a pseudo-diarrhea. It's not a true diarrhea, but nevertheless, we put under diarrhea for our understanding. And the fourth one is the mucosal damage, diarrhea due to severe mucosal damage. So let us see what will be the stool volume. Stool volume typically will be less than 1 liter per day in the setting of osmotic diarrheas. It won't be more than 1 liter per day, but in a secretory diarrhea, it can exceed 1000 ml, 1 liter per day. Alternate motility, you cannot give such definitions in general. So we have only the causes because altered motility and mucosal damage, they typically don't cause diarrhea. They only cause pseudo diarrhea. The volume will not be the problem here. It's the number of times you pass the stools is the problem. So the true volume is not an issue here. So it will be usually normal in these situations. That's why I don't want to write anything. So then you have the content of the stool. And again, that is more important for the osmotic and secretory diarrhea. It's not important for the altered motility and mucosal damage. So as far as the stool content is concerned, it's predominantly water in osmotic diarrhea, because an osmotic substance is basically pulling off the like water from the body. So that's what it happens from the intestinal like wall. But here they don't only contain water, but they contain a lot of electrolytes. That is why the risk of getting dyselectrolemia is very, very high with secretory diarrheas compared to that of osmotic diarrheas, where they go for this hyponatremias, hypokalemias, acidosis very commonly. All these things are extremely common with secretory diarrheas compared to that of osmotic diarrheas. And again, there's no point in telling all these things in this setting. So if you do a fasting, in the sense like when you fast, so what will really happen? So when you're going to fast, like in osmotic diarrhea, your diarrhea will stop. So it no longer happens, because only if you take some osmotic substance, you're going to get a diarrhea. For example, lactose intolerance. So otherwise you don't get a diarrhea. Here, whether you fast or whether you don't fast, diarrhea will not stop. Diarrhea will continue. Because most often, for example, if you take cholera for that matters, cholera is not due to an osmotic substance. It's due to cholera toxin. Whether you take food or not doesn't matter. Your cholera toxin will keep producing, keep activating your CFTR, and you're going to cause continuous chloride efflux, and you are going to result in diarrhea no matter what. So diarrhea will continue despite fasting in the setting of a secretory diarrhea. And there is something called a stool osmolar gap. So which you calculate by a different formula, which I'll tell you later on how to calculate a stool osmolar gap. But in general, in osmotic diarrhea, the osmolar gap will be more than 100, whereas in secretory diarrhea, the osmolar gap will be less than 50. And it's quite expected as well. And again, there's no point in telling all these things here. And finally, whether you will get pain or not is the question. So as far as pain is concerned, usually, osmotic diarrheas are painless, whereas secretory diarrheas can be painful. This is not the general rule. It is only maybe. I'm not telling always. So sometimes osmotic can be painful and secretory can be painless also. But nevertheless, it's a common notion that osmotic diarrheas are painless and secretory diarrheas are basically painful. And again, there's no point in telling all these things here. So now let us move on to the etiology. So what are the etiologies? So typically, as I told you, one of the common reasons for developing an osmotic diarrhea is lactose intolerance. That is lactase deficiency. That's very common. So typically I can write as something called as a disaccharidase deficiency. Disaccharidase deficiency, in the sense like the very common example is something of a lactase deficiency that happens in children after some viral infections of the gastrointestinal tract. So which is quite common in children. And then it will be transient for that matters. So lactase deficiency, or it could be a trehalase deficiency, or it could be sucrase isomaltase deficiency. So some disaccharidase deficiency can produce this kind of issues. And due to undigested sugars in the intestine, like for example, once again, the common example is lactose, or it could be fructose, sorbitol, mannitol. So if you have some undigested sugars in the intestine, you might get osmotic diarrhea. Or if the patient is taking an osmotic laxative. So later on, we'll be discussing about laxatives. There are two types of laxatives. When you discuss about IBS, I'll talk about laxatives. There are two types of laxatives. One is you have osmotic laxatives and stimulant laxatives are there. If you're going to take osmotic laxatives, you're going to result in osmotic diarrhea. That's a no-brainer. For example, if you take something called as a PEG, polyethylene glycol, or if you're taking lactulose, or if you're taking magnesium-containing antacids, too much of magnesium-containing antacids like gelusil, so you might end up with getting an osmotic diarrhea. So especially osmotic laxatives, the common examples of osmotic laxatives is PEG and lactulose, very commonly used in the clinical practice. And if the patient is taking some artificial sweetness, like for example, they're taking sorbitol, xylitol, some artificial sweetness, so that can also cause an osmotic effect, and they can cause a diarrhea, like episodes on that particular day. So these are the usual causes of osmotic diarrhea. So then we have some cause of secretory diarrhea. As I told you, the quintessential and classic example of getting a secretory diarrhea is cholera. So infection is the usual reason for developing a secretory diarrhea. For example, the common examples will be like this enterotoxigenic E. coli, which causes something called as a traveler's diarrhea. And then we have cholera toxin, which causes secretory diarrhea as well due to CFTR stimulation. And you know that we're not going to discuss all those things. And you have undigested bile acid, that's called a bile acid diarrhea or bile acid malabsorption, which we'll be discussing later on. Then if you have a stimulant laxative, as we discussed, we have a lot of stimulant laxatives like senna, cascara. So many stimulant laxatives are there, which we'll be discussing later on. So all the stimulant laxatives can cause this kind of secretory diarrhea. And for example, tumors, especially the pancreatic neuroendocrine tumors like VIPoma, gastrinoma. In fact, you would have studied the triad of gastrinoma. One of the important components of gastrinoma triad is the diarrhea. Diarrhea is such a common entity with gastrinomas. You'll have weight loss, ulcers, diarrhea, very, very common in gastrinoma. So you should not forget gastrinoma. And you have VIPoma. Whenever question tells you explosive diarrhea, I don't know why in exam they like teachers, and most of the time they will give history of teachers getting explosive diarrhea. Usually in exam, it's a common, like punch word that tells you the patient is suffering from a VIPoma. So it's very important, and it can happen with carcinoid syndrome, which can also cause kind of explosive diarrhea, but most often they will give other features of carcinoid here. Or it can happen in patients who are suffering from medullary thyroid cancer, and this is due to calcitonin. This is due to calcitonin. And you know what is the reason for getting diarrhea in gastrinoma? The reason is the gastrin itself that increases gastric motility and causes diarrhea. VIPoma, the reason is vasoconstricting peptide. In carcinoid, the reason is serotonin. So these are the reasons for developing diarrhea in these conditions. Neuroendocrine tumors. Especially, these are also called as pancreatic neuroendocrine tumors. It can happen in diabetes, which is called as diabetic diarrhea due to osmotic effect of glucose once again. Or it can happen very rarely in a condition called as microscopic colitis, which we'll be discussing later on. So these are some classic examples of getting an osmotic diarrhea. But usual reason for developing an osmotic diarrhea, secretory diarrhea is infection, and usual reason for developing an osmotic diarrhea is either a laxative or probably a disaccharidase deficiency. Then coming to the altered motility. So I've told you already. So there are some conditions which produces increased motility, and because of that you will get a diarrhea. The best example, as I told you, is hyperthyroidism, and it can happen in post-gastrectomy states. Very, very common. Today also I saw a lady who underwent a sleeve gastrectomy like 4 or 5 years ago. Now she is telling that is persistently having diarrhea. The moment she eats food, she will have a diarrhea. So that is due to faster emptying. So that is what we refer to as something called as dumping syndrome. So which can happen in dumping syndromes as well. That is due to like faster faster transit of food from the stomach into the intestine because of gastrectomy. It can happen in carcinoid, VIPomas and all other situations, because even though VIP typically causes increased secretion also, but at the same time they increase the gastric motility also, so they act by multiple mechanisms. So if you want to be really non-confusing, then you can drop this off, not a problem. But nevertheless, they cause diarrhea by multiple mechanisms. And apart from that, there are some conditions that produces low motility. They don't really cause diarrhea, but still, because of low motility, you can encounter constipation. What are the conditions that produces low motility? Intestinal motility. Because of that, you will get constipation. One is diabetes. Remember, diabetes can cause diarrhea as well as constipation. Second is hypothyroidism, which produces constipation. Then systemic sclerosis, which is a well-known factor for constipation. Then amyloidosis, well-known cause of producing constipation. And finally, post-vagotomy states. Like vagus is the one that stimulates the intestine to produce more contraction. So if there is no vagus, no vagal tone in the intestine, of course, you are going to end up with constipation rather than diarrhea. So reduced motility. Apart from this, many neurodegenerative disorders like Alzheimer's disease, Parkinson's syndrome, these patients very, very commonly suffer from severe constipation. And patients who are taking opioid drugs, they can go for low motility, and because of that, they can go for constipation. So these are the conditions that produces low motility. So they don't produce diarrhea, but still they produce constipation. So one important thing to notice, diabetes can cause both constipation as well as diarrhea because of multiple mechanisms. So we don't want to discuss, that's beyond the scope of the discussion right now. And there are some conditions I told you which cause mucosal damage. So typically it causes we call it as invasive diarrhea, which means an organism is actually invading the intestinal tract and it's trying to move into the body, into the bloodstream, causing sepsis. The best example for invasive diarrhea is Salmonella, which causes mucosal damage, or it can happen in Shigella. Most of the time, invasive infections will result in bloody diarrhea because they cause heavy damage to the mucosa. Whenever there is severe damage to the mucosa, you will end up getting blood in the stools. So once I told you mucosal damage, blood in the stools, you should always think about the inflammatory bowel disease like Crohn's disease or ulcerative colitis, with special preference to ulcerative colitis, which causes typical bloody diarrhea. Remember, Crohn's disease will mostly come like a chronic diarrhea, then followed by constipation, but usually they'll be non-bloody. But whereas ulcerative colitis, one of the first presentations itself is bleeding PR and bloody diarrhea because of the proctitis they cause. And apart from that, it can happen in patients who are suffering from ischemia to the intestine. For example, an ischemic colitis. It can happen in patients who are suffering from vasculitis. I think in rheumatology, we have discussed one of the important vasculitis that causes gastrointestinal tract involvement is Chugh-Strauss syndrome, where I mentioned they cause eosinophilic gastroenteritis, and because of that, they produce bloody diarrhea. And you can think about HUS-TTP complex also. And again, that will come under infection. And apart from that, you have something called radiation enteritis. Because of radiotherapy, they can get severe damage to the mucosa, and that can result in bloody diarrhea. And because of severe diverticulitis itself, they can cause mucosal damage because of inflammation in the local area, and because of that, they can get up a bloody diarrhea. So this is how you classify diarrhea in the first place. And more importantly, what will be asked in exams, if you ask me. So most of the time, the differences between osmotic and secretory diarrhea is a common thing that will be asked in exams, like what is the volume, which is higher, where is the electrolyte that is going to be lost, and what is the effect of fasting on osmotic and secretory diarrhea, and what is the osmolar gap in the stool, and which diarrhea is painless and which diarrhea is painful. And when it comes to causes, usual reason for osmotic diarrhea will be either a laxative, like osmotic laxative, very common cause in the current era, and disaccharidase deficiencies and undigested sugars and artificial sweetness. So very benign causes most of the time. When it comes to secretory diarrhea, you most often think about infections. That's the usual reason for secretory diarrhea. But apart from that, it could be laxatives, bile acid related, or rarely deadly diagnosis like pancreatic neuroendocrine tumors. Diabetes causes osmotic diarrhea or secretory diarrhea. Very commonly, diabetes, if it causes diarrhea, it will cause secretory type of diarrhea only. They won't cause osmotic type of diarrhea, because the mechanism of getting diarrhea is multiple. In the sense, like they cause altered intestinal motility, and they cause small bowel bacterial overgrowth, and so many reasons are there. So usually, if you weigh and see, diabetes is going to cause only secretory diarrhea. They're not going to cause osmotic diarrhea, and they do cause altered motility also. So a lot of mechanisms are there in in diabetes, but again, we don't want to discuss in detail. And I told you, what about altered motility and what about mucosal damage? In that thing, we are not discussing about the stool osmolar gap. How will you calculate the stool osmolar gap? So first of all, you need to know what is the normal stool osmolality. How will you calculate the stool osmolality? What is the formula for stool osmolality? Stool osmolality calculation is done by a formula that is telling that 290 minus 2 multiplied by stool sodium plus potassium. Stool sodium plus potassium. This is the formula for calculating the stool osmolality. So how will you tell osmolar gap? So it is like how we found out osmolar gap in the serum. The same thing we are going to find out here also, which means we are going to take the measured stool osmolality, minus calculated stool osmolality. Calculated stool osmolality. So usually there should not be much difference. Like if the difference is more than 100, that goes towards an osmotic diarrhea. If the difference is less than 50, that goes towards a secretory diarrhea. So that is the idea. The reason is very simple. When you calculate the stool osmolality in a patient with osmotic diarrhea, they will have the same amount of, they will have a little bit of less amount of osmolality. That is because of the dilution when you measure it. So that is why it will be a little difference will be there. But in a secretory diarrhea, the actual thing will actually mimic the calculated osmolality. That is because it is actually a kind of secretion. So there will be more sodium and more electrolytes in the stool. So there is a little, water will be proportionate. So that is the reason the osmolar gap will not be that high. But in the setting of, osmotic diarrhea, because of the discrepancy between the amount of water and the amount of electrolytes, this difference will be there. So in a simple way to tell. So, but nevertheless, they don't ask that much, but you need to know that more than 100 in osmotic diarrhea and less than 50 in the setting of secretory diarrhea. So that is why, these are the points that is generally asked in exams. Apart from that, you can divide the diarrhea into many things. So most of the time they will ask you the approach to acute diarrhea. So how will you manage, or how will you approach an acute infectious diarrhea? I mean, we are thinking it's infectious because most of the acute diarrheas will be infectious. So we are going to approach an acute infectious diarrhea. So this table will be, whatever algorithm I'm going to give will be very, very helpful for you. That is because most of the time they will ask you a clinical setting. So how a patient should be approached when the patient is coming with an acute diarrhea. So what kind of infection you might be expecting. So how will you classify is the phase? Whenever there is a diarrhea, there might be vomiting also. It's not like the patient comes with truly diarrhea only. There might be vomiting as well. So you need to classify into whether the vomiting is predominant or patient is having a short incubation period. So let us see. So first I'm splitting into two. So vomiting predominant. It's not diarrhea that is predominant. Diarrhea is there, but vomiting is the predominant thing. And patient is having a very short incubation period, in the sense within 6 hours they're developing severe vomiting or probably a little bit of diarrhea. So in this setting, very commonly it will be due to toxin mediated diarrhea. Toxin mediated in the sense like we're talking about a preformed toxin here. Preformed toxin. It's not toxin that is produced after you consume a food. It's like a toxin that is formed even before the food is consumed. In the container itself, the toxins are there, the bacterial toxins are there. Very commonly, this might be caused by Staphylococcus aureus, or it could be Bacillus cereus. We know that. So usual clue in exam for Bacillus cereus will be this. Recooked Chinese fried rice. So these are the usual clues in exam will be there. They were taught in microbiology. If you want me to tell, I'll tell later on. But the clues will be very simple. So if you have a meat and all these things, then you can go for Staphylococcus aureus in exam. If you have this fried rice kind of a thing, reheated rice. So if you give this kind of clues in exam, you can go for Bacillus cereus. So these are due to preformed toxins, by the way. So very simple. And remember, basically, this needs only supportive management. Please understand that they are toxin mediated, in the sense like you cannot give any treatment for this toxin. So they will go automatically over a period of time. Actually, there is no bacteria in the food. It's just the toxins that is caused by this bacteria that is there in the food that is causing the vomiting or diarrhea. So really, you need not worry much about it. You just leave them and just give a supportive management. And within some few days, like 1 or 2 days, they will recover. So there is no antibiotics and that is needed, or there is no extensive management that is required. So just manage them with supportive treatment, just fluids, and continue the oral feeds and give some antiemetics, and that must be enough. So when you talk about diarrhea predominant, so go for the diarrhea predominant. So now you can further split into two, whether the patient is having blood in stools or whether the patient is not having blood in stools. Nikki is telling screen not seen. I think the screen is seen. So if the screen not seen, I don't think there is a problem. Screen is seen. Anyone who experiences the same problem of screen not being seen? Okay. There's no problem. Everyone is able to see the screen. Okay, cool. So I think he has to refresh or do something. NKY. Okay, not an issue. So let us move on to diarrhea predominant. So because initially we thought about vomiting predominant, short incubation period. Now we are moving on to diarrhea predominant disease. Diarrhea predominant based on blood in stools. You can classify into two. See the blood in stools. The first one is no blood in stools. No blood in stools. And the patient is typically having a predominant watery diarrhea. And once the patient has blood in stools, they will typically tend to have more of a mucoid diarrhea. So let us assume it's more of water rather than mucus, and there is no blood in stools. And whenever you see blood in stools, it will be more of mucus rather than water. So no blood in stools, typically watery diarrhea. Usually it means the patient is suffering from a non-inflammatory diarrhea. As simple as that. So without inflammation, you don't get blood and stools. And without inflammation, you'll get more of water only. When there is inflammation, you tend to get more of blood and it will be more of mucoid. So I can tell it's more of an inflammatory diarrhea. That's how I'm going to split into two. That's why the seeing the blood and stools is very, very important. So once I know it's a non-inflammatory diarrhea, so based on immunocompromised status or immunocompetent status, I can divide into two. So in the sense like one, I can talk about immunocompetent individuals, which is very common scenario, or I can encounter immunocompromised individuals. In general, immunocompetent individuals will have a short history of diarrhea. They don't have a long history of diarrhea. Whenever you have immunocompromised individuals, they tend to have a long history of diarrhea in the sense like either it will be a persistent diarrhea or it will be a chronic diarrhea. So usually immunocompromised individuals will encounter a long-term diarrhea. So whenever it's immunocompromised, getting a persistent or a long-standing diarrhea, best example for this is you can think about a patient who's suffering from HIV, very, very common scenario get in exam. So you can think about certain organisms like Cryptosporidium parvum, or you can think about Isospora belli. You know how to differentiate all these things. You should have a strong microbiology behind that, how to diagnose all these things by your microbiological analysis, because these are very basic common questions in exam. Or it could be Cyclospora caedenensis, or it could be Microsporidium species. So in all among these four, if you pick out the most common, it's always going to be Cryptosporidium parvum. So that's going to be the most common thing that causes diarrhea in these individuals, especially patients who are suffering from HIV. And most of the times they will be not having fever, afebrile. So they just come with a watery diarrhea that will be persistent and long-standing. One rare condition that can come similar to this is, so don't forget this also, it could be giardiasis. Giardia could also be a possible pathogen in this scenario, a long-standing persistent diarrhea. But diarrhea usually will have malabsorption, features of malabsorption. And giardia usually will have foul-smelling diarrhea. And sometimes, by investigations, you can pick out this giardiasis. So, I mean, again, I'll talk about giardiasis later on how to find out. But nevertheless, so this is how you think about it. Whenever they typically give malabsorption and foul-smelling diarrhea, and the patient has features of malabsorption also, then you can think about giardiasis in this setting. But nevertheless, these are the usual differential diagnosis under this setting. But how will you treat each and everything? In the sense, like how you are going to treat Cryptosporidium, how you are going to treat Isospora, how you are going to treat Cyclospora, how you are going to treat Microsporidia, how you are going to treat Giardia. So everyone knows that this is quite simple. Giardiasis, the usual drug that we prefer is giving a metronidazole. That's the usual drug that we're going to use. But what about Cryptosporidium? Cryptosporidium, what is the drug that we are going to use? Typically, if the patient is immunocompetent, so it's coming as an epidemic, the patient is not an HIV patient, then you can give nitazoxanide, which is quite effective in this scenario. Suppose if the patient is having HIV, then you have to initiate antiretroviral therapy. Plus or minus, you can use nitazoxanide. Remember, nitazoxanide in immunocompromised individuals like HIV patients has very poor role. We don't know how much it will help, but still it's only an option. But most importantly, you have to boost the immunity by giving antiretroviral therapies. That is the treatment. So when it comes to Isospora belli, so the Cyclospora and Isospora, you are going to treat with cotrimoxazole, trimethoprim, sulfamethoxazole. This is the treatment I'm going to use for Isospora and Cyclospora. Microsporidia will be treated with albendazole. Albendazole is the usual choice for treating microsporidia. These are the drug options that you need to know for different organisms for causing this persistent diarrhea in immunocompromised individuals. And then we have a big discussion left on immunocompetent individuals who are having non-inflammatory diarrhea or watery diarrhea. So based on the incubation period, I'm split into two. So patients who are having a very short incubation period, in the sense like very short, within 16 hours, not more than that, or 8 to 16 hours, somewhere around, short incubation period. And the patient is having no travel history. They have not traveled or not from a cholera endemic zone. So in these patients, you think about common conditions like Bacillus cereus, which is of diarrheal type, because Bacillus cereus is of two types. You would have studied in microbiology again. One is called emetic type and second is diarrheal type. So diarrheal type Bacillus cereus will have a little bit of longer incubation period, 8 to 16 hours, but still it is due to preformed toxins only. And second, Clostridium perfringens can cause this. And again, both are due to preformed toxins only. Because it is due to preformed toxins, patients will once again be afebrile. They don't have fever usually. And here also I can write afebrile because it's due to preformed toxins. Preformed toxins will not result in fever. So afebrile. And how will you treat them? Once again, you are going to just treat by supportive management. So whenever it's due to preformed toxins, there is no need to treat this patients with antibiotics. You're just going to treat in a supportive manner. So a little bit of longer incubation period. In the sense, I'm talking about incubation period of maybe 24 to 72 hours, around 1 to 3 days incubation period. Not short, it will be a long incubation period. So you're going to think about some infections, which are a little bit more of damaging the mucosa also. Like for example, you see the travel history here, or if the patient is coming from a cholera endemic zone, So depending on that, if the thing is yes, then you can think about ETEC. That is the typical cause of a traveler's diarrhea. So that is if the patient is having a travel history. The patient is having typical travel history and coming with the diarrhea after that. So you can think about ETEC. That is enterotoxigenic E. coli, which typically causes something called as a traveler's diarrhea. Or if the patient is coming from a cholera endemic zone. In this setting, I can think about a cholera. Remember, cholera will in exam will have a lot of clue. Typically, the patient will be passing that classic rice water kind of stools, and you'll be getting cholera in an epidemic. You don't get cholera as a like isolated case. Usually, from the same area, there will be multiple patients who will be coming. So, coming from a cholera endemic zone, which happens as a typical endemic, clusters of cases will be there. Along with that, if the clue tells that the patient is having typical rice water kind of appearance, then in this setting, you can think about cholera. Remember, ETEC and the cholera, both are again due to toxins. But in this setting, it's not due to preformed toxins. Remember, there is a difference between preformed toxins and there's a difference between toxin that is formed after the bacterium is ingested. In cholera and ETEC, the toxins are formed after the bacterium is ingested. So it will be more severe. So, but the patient will still be afebrile. You might wonder in cholera, the patient will be afebrile or not. Yes, cholera is non-invasive diarrhea. The reason for diarrhea in cholera is the toxin, not the bacterium itself. Of course, the bacterium also causes, the bacterium is the one that causes the toxin release, but nevertheless, it doesn't invade. Cholera does not cause septicemia. It doesn't cross the mucosa and go into the body and they produce cholera sepsis. They just stay in the intestine, they produce the toxin, and that toxin is the one that's going to cause that severe secondary diarrhea and death of the individual. So usually the patient will be afebrile because the bacterium is not actually going into the body. They don't cause sepsis. That is the reason. Suppose if the patient does not have travel history and the patient is actually not coming from any cholera endemic zone, in this setting, very common situation is viral gastroenteritis. Usually viral gastroenteritis is the most common cause of diarrhea in the adults as well as in children. So there are two viruses you need to think about. One is the rotavirus and second is the Norwalk virus. Norwalk virus is also referred to as norovirus. Rotavirus is very common in children. Norwalk virus or norovirus is very common in adults. Especially in exam, what will be the clues for finding out this Norwalk virus? One is the age, of course. Adults have multiple reasons for diarrhea, but in adults, how will you think it's a Norwalk virus? Very commonly in exam, they'll give a clue with regards to eating of this seafood, especially crustaceans, the prawns, crabs. So whenever they get diarrhea after eating this seafood, you can think about Norwalk virus because Norwalk virus is seen in this seafood, especially this crustaceans, prawn, crab and all. That is why think about Norwalk virus if the adult patient is getting diarrhea after eating a seafood. Very classic. And that is why the other name for Norwalk virus diarrhea or norovirus diarrhea is also called as cruise ship diarrhea. What do you mean by cruise ship diarrhea? Because in ship, very common food that is available is the seafood. Because, that's a common sense. So because they eat a plenty of seafood, sometimes the whole crew can get diarrhea because of this norovirus. So that is why it's also referred to something called as a cruise ship diarrhea. But nevertheless, so very rare causes dysteria, but it's extremely rare. You don't get in exam. You'll have a clue of eating raw cheese or unprocessed cheese. Pregnant women, extremes of age. You can think about listeria, but in general, listeria is something you should not think about in exam because it's a very very rare cause. But remember, usually they tend to be febrile. These patients tend to be febrile because this is actually due to organisms and not due to toxins. So they will elicit an inflammatory reaction and they generally develop a fever in this situation. So till now, so many causes of diarrhea we have seen, right from the Staphylococcus aureus, Bacillus cereus, Clostridium perfringens, ETEC, cholera, and we have seen the Cryptosporidium, Isospora, Giardiasis. Out of all these things, we have seen fever only in viral gastroenteritis. I mean, fever is plus or minus only, since like not all the patients will get fever. Few patients may develop fever, but think about viral gastroenteritis. Among all these causes, the most important is this only. This viral gastroenteritis may cause fever at times. So whenever you get an inflammatory diarrhea, typically in all these situations, fever is extremely common. Number two, second thing that you need to know. So fever is common, but they may or may not have fever. So typically, I mean, let us see two situations, two classic scenarios in this example. So let us see a child who's typically not having a fever or only mild fever is there. Mild fever is there. This is something you should answer. Mild fever is there and coming with a frank bloody stool. What do you think about in this scenario? The patient is having a frank bloody stool. What do you think in this scenario? So what could be the real possibility here? Child, mild fever, frank bloody stool. I mean, it is about diarrhea that is going to cause HUS-TTP complex. So we know that is typically referred to something called EHEC. Like think about EHEC in exam. That is enterohemorrhagic E. coli, typically due to the toxin that is going to produce. That is the O157H7 or O154. I mean O104H4. So there are two types of toxins are there. You have to think about enterohemorrhagic E. coli in this setting, which can be causing a sequelae called as hemolytic uremic syndrome. Or if the patient is having, I mean, high grade fever plus having only occult blood in stool, they're not having frank blood, having only occult blood in stools, and it happens in adult individuals. What are the options that you have? So typically, you are going to think about invasive diarrhea here, in the sense like there is some infection that is causing invasion into the gastrointestinal tract. So there are multiple reasons for that. Very commonly, it will be salmonellosis. This is also a very common case that we encounter in practice. That is, these are called as non-typhoid salmonella. You would have encountered that. There are many different groups of non-typhoid salmonella are there, but they are the usual reasons for this kind of invasive diarrhea. Or it could be Shigella. Some Shigella species can cause invasive diarrhea. Or Yersinia enterocolitica. Or it could be a Campylobacter jejuni. Or it could be due to Entamoeba histolytica or amoebic gastroenteritis, or it could be Clostridium difficile. Each and everything is actually encountered in different scenarios. We don't want to discuss in detail, but in general, whenever you talk about Clostridium difficile in exam, there will be clearly history of broad spectrum antibiotic use. Broad spectrum antibiotic use. So amoeba in exam clues will be like from amoeba, I mean, low socioeconomic status. That is the clue. And apart from that, they might be producing this flask-shaped ulcers in colonoscopy. And they might be having extraintestinal involvement also, like liver involvement and all these things can be there. Pleural effusion can be there. Amoebic liver abscess can be there. So these are the clues to tell that the patient is suffering from Entamoeba histolytica related diarrhea. But nevertheless, so these are the usual reasons for getting a invasive diarrhea. But one of the most important thing is to understand the differential diagnosis. So there is one non-infectious condition that can typically produce an invasive diarrhea-like appearance. So that is IBD. So IBD is the most important differential diagnosis, especially ulcerative colitis, which can produce all these features like this fever, occult blood, or even frank blood, adult patient, like having bloody diarrhea. So think about IBD. So this is one of the most important non-infectious cause. But even the IBD will most often cause persistent or chronic diarrhea rather than causing acute diarrhea. But most often, you need to think as a very important differential diagnosis when you're thinking about an infectious cause. Now coming to the antibiotic choice. So whether you have to use antibiotics or not, yes, you have to use for invasive diarrhea. For example, if the patient is having salmonellosis. So how will you treat a patient with salmonellosis? Salmonellosis is the best drug that we right now use is ciprofloxacin for non-typhoid salmonella cases. Even though resistance is very high right now in India especially, but nevertheless ciprofloxacin is still considered to be most important drug as far as CDC recommendation is concerned. As far as Sigilla is concerned, still I'm going to use ciprofloxacin only. There's no doubt about that. As far as Yersinia enterocolitica is concerned, I'm going to use doxycycline. As far as Campylobacter jejuni is concerned, I can still treat with doxycycline, not a problem. Entamoeba histolytica, we know I have to give metronidazole plus along with that paramomycin. That is for treating the luminal disease. So this is the usual choice that you need to use for amoebiasis, metronidazole plus paramomycin. As far as Clostridium difficile is concerned, right now the first choice will be oral vancomycin. Alternative will be metronidazole. Metronidazole can be given oral as well as IV, but metronidazole right now is only an alternative. If at all, if you are answering an exam question, the first choice will always be oral vancomycin in this situation. IBD, there's a different treatment. You don't treat with antibiotics, by the way. And do we left anything else? Yeah, we have not talked about this ETEC. So what is the treatment drug antibiotic that you can use for enterotoxinic E. coli, traveler's diarrhea? Typical antibiotic is ciprofloxacin. There are some textbooks which will azithromycin also, but ciprofloxacin is the classic drug that we use for traveler's diarrhea, enterotoxigenic E. coli. And for cholera, once again, we know the best drug is doxycycline, just 3 doses of doxycycline given as a stat dose, single dose, 300 milligram of doxy, 3 tablets of doxy. Each tablet will be 100 milligrams, so 3 tablets of doxycycline, single dose is enough for treating cholera. That is what the recommendations by multiple guidelines are. So doxycycline becomes the best drug or most important drug for cholera. Then when it comes to this enterohemorrhagic E. coli, so what is the drug that you're going to use? Remember, antibiotics are contraindicated. So that is the point I need to tell. Very, very important. When it comes to enterohemorrhagic E. coli, when you're suspecting a HUS, especially in children, you should not use antibiotics. Antibiotics are basically contraindicated in this situation, which is very, very, very important point to know. So I think we have discussed everything. So right from the differential diagnosis to the treatment choices, we have discussed everything. So remember, preformed toxins does not needed to be treated with any antibiotics. Apart from the ETEC, ciprofloxacin, or probably azithromycin, and cholera, doxycycline, of course. And viral gastroenteritis, again, it doesn't need any treatment. No antibiotics are there. It's only supportive management. In fact, antibiotics won't work if you're dealing with a viral gastroenteritis. And probably for Listeria, you have drugs like ampicillin, but right now, leave it off. Most of the times, these kind of diarrheas, you don't treat with antibiotics. Cryptosporidium, nitazoxanide, Isospora, Cyclospora, cotrimoxazole, Mycosporidium, albendazole. Then gyardiasis, of course, it's metronidazole. And EHEC, enterohemorrhagic E. coli, that, what is that? HUS complex, you generally don't use antibiotics. In fact, fever and frank blood in stools is the contraindication of giving antibiotics. And patient is having salmonellosis, means ciprofloxacin, Shigella ciprofloxacin, Yersinia and Campylobacter doxycycline, Entamoeba histolytica, that is metronidazole and paramomycin. And finally, for Clostridium difficile, you're going to use oral vancomycin as the first option. If not available, then you can go for metronidazole. So these are the usual options. And this is how you approach a diarrhea as far as exams are concerned. And they might be asking you about the rehydration strategies also. I'll be telling about the indications for antibiotics and what about the rehydration strategies. So the most important strategy for treatment of diarrhea is any diarrhea for that matters, especially acute infectious diarrhea, is rehydration. As far as rehydration is concerned, ORS is the most important. Even though IV fluids are preferred, IV fluids are generally preferred only in patients who are not able to take oral feeds. So that is how the guidelines are. But even though we don't follow that, most of the times we give IV fluids for any patient who suffer from dehydration. That's a common practical notion. But nevertheless, as far as theory is concerned, IV fluids are not used unless until the patient are suffering from severe dehydration Or if the patient is not able to take oral feeds, we need not give IV fluids. We can just manage with oral rehydration solution. So as far as rehydration is concerned in exams, the ORS is a cornerstone. So they will be asking you about the ORS. So you need to know about what is the difference between a standard ORS and what is the difference between there is something called a low osmolality ORS. Currently, the WHO recommends this low osmolality ORS, but let us see the difference. So because the rehydration solutions will contain glucose, they will contain sodium, they will contain chloride, they will contain potassium, they will contain, of course, the citrate, and what will be the net osmolality. So all these things have been asked multiple times in the past, especially this is given in a lot of PSM textbooks as well. But let us see. So as far as standard ORS is concerned, the amount of glucose is 111 milligrams per deciliter, sodium is 90 millimoles, chloride is 80 millimoles, potassium is 20 millimoles, and citrate is approximately 10. And if you take the total osmolality, it will be approximately around 311. So this is the osmolality of a standard ORS. As far as low osmolality ORS is concerned, glucose 75, sodium 75. This is one of the key things that's done in recent past. That is the equalizing the osmolality of the glucose and the sodium, and they make it low osmolality. So 75, 75, 65 for chloride. Then I think potassium you have 20, and there's no change in citrate. It's 10. I think the net osmolality will be 275. So this is the osmolality of net osmolality of a low osmolality ORS. That is 270. Not 275. I think it will come at 245 only. 245. So this is the low osmolality ORS. So what is the amount of glucose overall it is added? So what are the contents? What are the components of a standard ORS? So this is also something they'll be asking. Glucose that is added is 13.5 grams per deciliter. This is the total amount of glucose added in the solution. And there is something called a trisodium citrate. This is not the case. This is for low osmolality ORS. So what is the amount of glucose that is added in the low osmolality ORS? That is 13.5 grams per deciliter. And there is something called trisodium citrate. Citrate dihydrate. The amount that is added is approximately 2.9 grams per deciliter. And there is something called KCl, and they will be adding NaCl as well, sodium chloride as well. Amount of KCl that is added is 1.5 grams per deciliter, and the amount of NaCl that is added is 2.6 grams per deciliter. So these are the different components, amount of salts that are added in the low osmolality ORS. So this is again a very, very important and valuable question exam. You need to definitely know this. So first of all, compared to standard ORS versus low osmolality ORS, the balance is more towards low osmolality ORS. This is what they're going to ask in exam, if at all they want to ask. Apart from that, the numbers you need to know for sure, especially for low osmolality ORS. And apart from that, what is the amount of salts that is mixed is also very, very important. They might be giving as an MCQ. So all of the following are true except. So they might give one of the numbers and ask which of the following is false. Or they might be asking one of these numbers and ask which of the following is false. So they might ask these kind of questions, which are quite common. So you need to know the numbers. And without knowing the numbers, you can't answer this type of questions. Of course, impossible. So this is for rehydration. And remember, they will ask you who will you give IV fluids. IV fluids are preferred in two conditions. One is for patients who are having severe dehydration, and second, patients who are not able to tolerate oral feeds. So these are the places where you need IV fluids. Apart from this, if the patient is able to tolerate oral feeds, and if the patient is not having severe dehydration, then ORS is the key. ORS is the most important. Which ORS you will prefer? Whether you will prefer low osmolality ORS or standard ORS, of course, I'm going to prefer low osmolality ORS. So what is the advantage of low osmolality ORS? Low osmolality ORS will definitely reduce the need for IV fluids. For that matter, any ORS will reduce the need for IV fluids. Second thing, they will reduce vomiting, and low osmolality ORS will have reduced stool volumes, because the more higher osmolality you give, there could be a possibility of osmotic diarrhea also. To prevent that, they made it low osmolality ORS, which is more beneficial compared to the standard osmolality ORS. So low osmolality ORS will reduce the need for IV fluids, will reduce the incidence of vomiting, and will reduce the amount of diarrhea also, reduce the stool volumes also. So when it comes to diet, the usual diet that is prescribed by WHO is something called as Brad's diet, even though the evidence for this is very poor. But Brad's diet is something that is suggested by WHO. So as far as Brad's diet is concerned, what are the diet we can give? Banana, rice, A for apple. We are actually going back to the LKG, isn't it? A for apple, P for banana, R for rice, T for toast, and S for soups. So this is what we refer to as a Brat's diet. And in general, whether to give dairy products or not, it's better to avoid dairy products. This is very, very important because it's a very common notion that we tell the patients to take curd rice whenever they have diarrhea. That's something which is ridiculous. Most of the times, it's better to avoid dairy products, especially in children, because most of the childhood diarrhea cases will be of viral gastroenteritis, and viral gastroenteritis usually will result in some amount of lactose intolerance, and when you take dairy products, they might result in development of more diarrhea. So generally, try to avoid dairy products. Adults, okay, but still, I don't prefer giving a dairy product in any patient with diarrhea because you don't know who's going to have lactose intolerance after viral gastroenteritis. So it's better to avoid. Don't give dairy products as much as possible. And there are some adjunctive therapies, like for example zinc has the best evidence for children, not for adults, especially in children. If you give 10 to 20 milligram per day for 7 to 10 days, so this has the best evidence. This has the evidence to reduce the incidence of diarrhea and increase the mucosal regeneration faster. So that is why use in children. In adults its use is questionable, but in children you can use zinc. And antibiotics, as far as antibiotics are concerned, there are some quite indications for antibiotics. More than indications, you need to know the contraindications first because they are the most important. Number one, gross blood in stools, which means the patient is telling a frank blood in stools. You should not give antibiotics. Antibiotics are contraindicated, and typically, if you know that the patient is having STEC, that is O157H7 grown in culture, or O104H4 grown in culture, because this again tells you that the patient is suffering from hemolytic uremic syndrome. So if you grow in culture, stool culture, if you get this STEC, or if you are having a gross blood in stools, this becomes a very important contraindication of starting antibiotics. What are the indications, which are not that important for exam, but the contraindications are the ones that are very, very important, especially when they give frank bloody stools, especially in children. Never ever start with antibiotics. Very, very important. And number one, if the stool leukocytes are positive, if they clearly give the fecal leukocytes are positive, then you can give a course of empirical antibiotics. We call it as GUAC positive. What do you mean by GUAC positive? Occult blood positive, because we do something called a stool occult blood testing. If that is positive, that is GUAC positive, then if the patient is having evidence of sepsis, high total count, fever, mucoid diarrhea, so in that setting you can give antibiotics. People who are immunocompromised and having a persistent diarrhea, definitely it will be infectious, and you can give empirical antibiotics in this setting. And patients who are old age, again likely to be immunocompromised, that's why age more than 65. And patients who are having persistent diarrhea, I told you persistent diarrhea can be infectious, especially immunocompromised individuals, and patients who are coming from a cholera endemic zone. Or if you see a cluster of cases with typical rice water kind of stools, then in that setting, of course, you are going to take and treat it as cholera. And of course, you are going to give doxycycline 3-stat for all these individuals. 3-stat in the sense like 300 milligram of doxycycline stat dose. That's what the treatment regimen will be. So these are the indications for giving antibiotics in patients who are suffering from diarrhea. Clear? And again, it has to be weighed. You really can't differentiate in reality whether it's a toxin, preformed toxin, unless until you take a clear history and what food they have eaten. You'll not be able to really tell whether it's, like preformed toxins, or toxins are formed after coming into the body, or it could be invasive. So we don't really predict all these things just by history. You need to have uh, a lot of considerations. So, but nevertheless, pure watery diarrhea you can manage without antibiotics. Supportive management initially. Rest apart, like many other diarrheas can be managed with antibiotics. But most importantly, contraindications are the most important. Blood in stools, frank blood in stools or frank bloody diarrhea is a very important and a big contraindication for starting antibiotics. You should not give. So that's the important point in exam. Then what about anti-secretory agents are there? We have some anti-diarrheal agents and anti-secretory agents are there. What are the anti-diarrheal agents? So remember, usually anti-diarrheal agents can be given in watery diarrhea. Better to avoid in non-watery diarrhea. But in watery diarrhea, you can try anti-diarrheal agents. There are two types of antidiarrheal agents. One is anti-motility agents that we use. Second, we have anti-secretory agents. There are two types of that. one of the common drugs that we use here is loperamide. Loperamide, very, very common drug. Loperamide is a common drug. Generally, we use in a dose of 1 to 2 milligram per day. So loperamide is a common anti-motility agent. It's like an opioid drug. And anti-secretory agent as such, there are two drugs are there. One is the bismuth, which is uncommonly used. Right now, what we commonly use is something called as rusticadotryl. This is a common drug that we use. It's available in the brand name called Redotil. We give it a dose of 100 milligram 2 to 3 times a day. This is a common dose that we use. That is rusticadotryl. So usually they will ask you the mechanism of how rusticadotryl works, how it becomes an anti-secretory agent. It's not anti-motility, but it's more of an anti-secretory agent. So we can write it as an intestinal enkephalinase inhibitor. That's something they might ask in exam. So intestinal enkephalinase inhibitor. So which means what they will do is they will actually block the enzyme called enkephalinase that will increase the levels of enkephalins in the intestine. So increased enkephalins will result in reduced cyclic AMP, and reduced cyclic AMP will result in reduced chloride and water secretion. So typically the most important indication of rusticadotryl is a secretory diarrhea, but nevertheless for most of the diarrheas it works. So it's like kind of an anti-secretory agent rather than anti-motility agent. The true anti-motility agent that we use in practice is loperamide, and this is an anti-secretory agent, by the way. So I think rest of the things you can study in microbiology, because I don't think we don't want to waste time by discussing on the microbiology stuff. But nevertheless, this will give you a good idea about how to approach a diarrhea and how to treat a diarrhea in exam. So what all we have discussed. Let us put a recap. So initially we have started with what is the difference between osmotic and secretory diarrhea, and we also discussed on other types of diarrhea which is due to altered motility and mucosal damage. And we have divided diarrhea based on the incubation period and whether vomiting or diarrhea predominant. And later on, if it's vomiting predominant, you're going to divide based on like preformed toxins or not. Most of the vomiting predominant conditions will be due to preformed toxins having a short incubation period. Then we have talked about diarrhea predominant disorders, and we have further split based on whether blood in stools are there or not, whether it's more of a water or more of a mucus. If it's more of a water and no blood in stools, it will be non-inflammatory. Non-inflammatory can happen in immunocompetent or immunocompromised individuals. Compromised individuals, we had a set of differential diagnosis and we discussed about how to treat them. And in immunocompetent individuals, depending on travel history and cholera and MCOMS, the two most important things that has to be kept in mind is ETEC, that is traveler's diarrhea and cholera. I told you how to treat those disorders as well. And if the patient is not having travel history and not coming from a cholera endemic zone and features are not suggestive of cholera, then most common cause will be viral gastroenteritis, and you're going to treat it supportively only. In adults, it's norovirus, and children, it is rotavirus. And apart from that, if the patient is having fever and blood in stools and it's more of a mucus, we think about inflammatory diarrhea. Frank blood in stools, children think about Shija-like toxin, that is enterohemorrhagic E. coli. Mostly occult blood having a good fever and it's an adult individual, think about invasive diarrhea like non-typhoid salmonella. I told you a list of organisms which can cause similar illness. And most important, non-infectious differential diagnosis for the same is inflammatory bowel disease. And there are 2-3 cornerstones for treating a diarrheal illness, especially acute diarrhea. One is the rehydration, and you need to know about the components of low osmolality ORS. And second is the diet. Third is this anti-diarrheal agents. And fourth is antibiotics. And fifth is zinc, which is typically useful in children and not in adults. So these are the common questions they are definitely going to ask as far as exams are concerned. If you understand this, let us move on to the next topic. Do you understand this? Diarrhea is a bit of a boring topic, but what to do? So you might be getting questions in exam. Do you understand? Yes or no? I guess it's yes. Okay. Yeah, I told you all the important topics on things on diarrhea, but you need to complete the microbiology part. So until you complete the microbiology part, this is not complete, because most of the organisms have some special features and how to diagnose under the microscope and what are the culture media. And these are the things they might be asking additionally. And don't forget to complete this session with the microbiology part. A good candidate, of course, now we'll be having a clear idea of how to approach a diarrhea, but he will complete this session by reading the microbiology part also. At least some key standard points you need to know in the microbiology. Clear? So don't forget. So once you read this, always complete with the microbiology part and make a good notes of it. And now we are entering into the topic that is completely related to medicine, that is malabsorption, because this is one topic that you won't have a good discussion in surgery. So let us start with malabsorption. Very, very important key topic in exams. So first of all, they will talk about a classic triad of malabsorption, how malabsorption is going to come. Malabsorption typically is going to come with a chronic diarrhea. As I told you, most of the chronic diarrhea will be non-infectious unless until the patient is immunocompromised. So chronic diarrhea is one of the important differential diagnosis, malabsorption. And the patient will be having weight loss because it's a catabolic state. They are losing nutrients. They cannot absorb them. And of course, they will be coming with anemia because of B12 deficiency, iron deficiency. A lot of micronutrient deficiency will happen because they'll be having anemia. So chronic diarrhea in the sense they might be having steatorrhea, especially if they cannot absorb fat properly, then they might be having steatorrhea. So this is a classic triad, even though seen in less than 20% of the patients. Any classic triad in medicine will be seen in less than 20% of the patients, but nevertheless, this is the classic triad of malabsorption given in any standard textbook. And there are two important complications that you might get in association with malabsorption. One is the renal stones, and second is the gallstones. So renal stones will be typically made of oxalate. General, the risk of getting oxalate renal stones is high with malabsorption. And second one is the cholesterol gallstones. This is something you need to know. Very, very commonly asked in exam. I mean, right now, I don't know whether they will ask or not, but in 2015 to 20, I can tell multiple questions that came in this area. So in malabsorption, the typical type of renal stones you get is oxalate stones, and the typical type of gallstones you get is cholesterol stones in the gallbladder. So why is that so? Usually in malabsorption, there will be fat in the intestine. So in the sense, a lot of fat will be there. Fat is not getting absorbed, so there will be a lot of fat in the intestine. This fat, of course, is going to chelate the calcium because fat is a very good binder of calcium. They bind calcium. So that's called a saponification reaction. We know that. So fat binding with calcium is called saponification. So fat traps calcium. So the amount of free calcium in the intestine will be less. So calcium, indirectly, it's an chelator of an oxalate. So whenever calcium is trapped by fat, there will be less free calcium to trap the oxalate. So there will be no more free oxalate. Free oxalate can be freely absorbed into the intestine. So there will be more oxalate in the blood that will be filtered by the kidneys. So there will be more hyperoxaluria, which will result in oxalate renal stones. So remember, the most common type of renal stones in the world is oxalate, and the most common type of renal stones you get in malabsorption is oxalate. Most common type of renal stones you get in Crohn's disease is oxalate. So whatever may be the case, when it comes to renal stones, the most common type is oxalate. Whenever there is a GIT pathology, the most common renal stones is also oxalate. That is typically due to fat malabsorption. So whenever there is more fat, less free calcium. Less free calcium means more free oxalate absorption, hyperoxaluria, oxalate stones. That's how you get renal oxalate stones in malabsorption patients. And second is gallstones. So gallstones is very simple. Again, because of fat malabsorption, see, bile is also fat, kind of a fat only. You can imagine like that. So the bile acids will not be absorbed properly. So because the bile acids will not be absorbed properly, there will be reduced bile acids in the like gallbladder, I mean the bile. So if you take the relative proportion of cholesterol to bile acids, the bile acids will be low, but the cholesterol levels will be very high because the bile acids are not absorbed properly and the intrahepatic circulation is lost. So the bile acids will be lost in the stools. So there will be reduced bile acids in the bile, and there will be relatively more cholesterol in the bile. So this is what we refer to as something called as a supersaturation of cholesterol in the bile. So that will result in the development of bile cholesterol stones in the gallbladder. So these are the common pathophysiology. But nevertheless, pathophysiology is important to understand, but the final take-home point is oxalate type of renal stones and cholesterol type of stones in the gallbladder. That's what you're going to get. So remember, whenever you get a malabsorption, typically it will be due to either a small intestinal disease. That's a very common scenario. Small intestine is the common area of pathophysiology, or it could be due to a pancreatic problem. So this is the these are the areas where usually result in developing malabsorption. Isolated stomach issues or isolated colonic issues, if they are isolated means in the sense like you don't have any other problem, only stomach or only colon, they generally don't cause malabsorption. Malabsorption is very rare in isolated stomach or colonic issues. For example, after gastrectomy, you develop malabsorption or not? Answer is no. You don't develop a malabsorption. You might develop micronutrient deficiency, that is different, but you don't develop a malabsorption, typical malabsorption syndrome. And in isolated colonic pathology, you don't develop a malabsorption. For example, after a colectomy, whether you develop malabsorption or not, answer is no. You don't develop malabsorption. Or in a patient with ulcerative colitis, whether you develop malabsorption or not, answer is no. You're not going to develop a malabsorption because ulcerative colitis is a disease that is confined to the colon. But Crohn's disease, you develop malabsorption or not, answer is yes, because Crohn's disease is affecting the small intestine. So you can develop malabsorption. But ulcerative colitis, answer is no. After colectomy, answer is no. After gastrectomy, answer is no. So these are the areas which are negative points that are very important, which are unlikely to cause malabsorption. So if the colonic pathology or gastric pathology is associated with the small intestinal pathology, which is the most common scenario, you will end up with malabsorption. So pure colonic pathology or pure gastric pathology, unlikely to cause malabsorption. That's the most important point that you need to know. So they don't cause malabsorption. Usually, if you have malabsorption, there will be definitely involvement of small intestine, or there will be involvement of pancreas, or pancreatic dysfunction will be there. So what is the micronutrient deficiency that you're going to get in reality? So let us see. It depends on the area of involvement. Clear? So let me show you a image so that you will understand. So what is the area of involvement? That is very important because different areas are involved in absorption of different nutrients. If you see this image, this is very important image, to be honest, even though it might look like it's not important, it's very, very important. So what is the proximal part of intestine is absorbing? What is the distal part of intestine is absorbing? Which area is absorbing water and sodium? So let me show you, highlight and show you that. I think this is something which is what I need to know. So if you see, there are quite a few points that are important here. One is the iron and calcium. Iron and calcium is very, very important. Iron and calcium typically is absorbed from the proximal part of intestine, especially from the duodenum. I mean, you can see the importance of stomach here, but duodenum is very, very important. Duodenum is the place where you typically absorb this iron and calcium. So whenever there is a proximal intestinal pathology, especially conditions like celiac disease, which affect the duodenum invariably, they will have iron deficiency anemia and hypocalcemia very commonly. And when you come to the B12, which is also very important, so B12 and bile salts and acids typically in the distal intestine. Whenever you have a distal intestinal pathology, like ileal resection, that is very commonly done in Crohn's disease, or any other surgery that is causing ileal resection, especially distal ileal resections, or if the patient is having a Crohn's disease, which typically most commonly affects the terminal ileum, or patient is having a tuberculosis, which again affects the distal ileum very, very commonly, you tend to have a B12 deficiency or bile acid diarrhea kind of situation, because bile salts and this vitamin B12 are typically absorbed from the distal part of the intestine, especially in the ileum. And when it comes to the disaccharides, this lactose and trehalose and all these disaccharides are typically absorbed in the jejunum. And remember, folic acid is something that, I mean, it is not given here typically about the folic acid. But if at all you ask about the folic acid is typically absorbed in the jejunum only again. It is not mentioned here, but folic acid, duodenum and jejunum, but more importantly in the jejunum. That's where folic acid is absorbed. So how can you remember? Duodenum, iron, jejunum, folic acid, and ileum, vitamin B12. And plus or minus, I mean, plus you can remember calcium also in the duodenum. And apart from B12, in the terminal ileum, you can remember the bile acids also here. So these are the usual things they will ask you in exam. Apart from that, you can see water and sodium is absorbed from the entire intestine. But one more thing that is also important to know is the potassium. So colon is something that secretes the potassium. That is very important. If at all they ask you which is the area of the intestine that has the maximum capacity of secreting potassium and reabsorbing potassium, answer will be colon again. these are some important points. Apart from that, if you want to go through the diagram, you can go through later on also. But whatever I mentioned here are the most important, regularly asked in exam. Based on that, you can tell so what is going to be the pathophysiology also. So when it comes to malabsorption, you can give, I mean, there are a variety of classifications are there, but I found out one classification to be very good. Usually I found this classification in two books only. One is Schleisinger's Gastroenterology, and second is Current Medical Diagnosis and Treatment Gastroenterology. I'm not talking about current medical, I mean, diagnosis and treatment. That is CMDT textbook. I'm not talking about that book. I'm talking about CDT gastroenterology, current diagnosis and treatment gastroenterology. There is one book is there separately for gastro. And second is Schlesinger book is there. In both these books, malabsorption is something that is given extraordinarily good. So you can have a very good idea and approach of how to manage a malabsorption, how to approach a malabsorption. So basically, when you want to know about the classification of malabsorption, you can divide into three types malabsorption. One are disorders where there is an impaired intraluminal digestion. Malabsorption, which is due to impaired intraluminal digestion. In the sense, there is some problem with digestive enzymes typically, and that is causing malabsorption. The best example in this situation is pancreatic disease. Pancreatic diseases, where, for example, a chronic pancreatitis, where there will be secretion of pancreatic enzymes will be defective because of the intraluminal digestion will be poor, because of that there will be loss of content from the gastrointestinal tract. Or it could be due to hepatobiliary disease, where the secretion of bile will be defective. Once your bile is not secreted properly, you cannot absorb fat and fat-soluble vitamins, and you will end up with deficiency of fat and fat-soluble vitamins with the development of steatorrhea also, which is a malabsorption condition. So hepatobiliary disease also can cause. You can get with post-gastrectomy malabsorption. So why after gastrectomy? Because the emptying will be very fast. So the movement of the content will be more faster than the absorption can happen. And the enzymes action also needs some time. So because the gastrectomy will result in more faster stool transit, because of that, you might end up with the malabsorption and a diarrhea. So that's why these are the common conditions. But the most important that you need to know in this under this heading is the pancreatic disorder that cause malabsorption. I'll come back to that. Then second thing is the conditions that produces mucosal damage. Because of mucosal damage, you're getting malabsorption, which means the mucosa is damaged so that they cannot work on the food particles and they cannot absorb the content properly. So the best example is the sprue. Here, where there will be mucosal damage, villus atrophy and all will be there. The two important sprues that you need to know is celiac sprue and tropical sprue. Tropical sprue is something that happens in tropical countries like India, but I mean, in general, in exam, usual questions will be on celiac sprue, but in India, tropical sprue is also very, very important, which you commonly encounter. And other conditions are there, like Crohn's disease is there, which is very important, where there's typical mucosal damage because of ulceration. And Whipple's disease is there. Whipple's disease is there, which is also going to cause mucosal damage. And it could be due to some parasitic infections, or it can be due to a condition called A-beta lipoproteinemia. And again, the problem here is impaired formation of chylomicrons. Only when you form chylomicrons, you can take this dietary fat and push into the blood and push into the lymph and then into the blood. So if it's not the case, you cannot form chylomicrons. That is the idea here. That is called A-beta lipoproteinemia. And radiation enteritis. Radiation can cause severe mucosal damage, and because of that, you can get malabsorption. And there are multiple other conditions. You have something called eosinophilic gastroenteritis, which happens in Chugstras syndrome and multiple other hypereosinophilic states. And we have systemic mastocytosis. We have carbohydrate intolerance. So many problems are there. But nevertheless, these are the common conditions that you need to know. In that, the usual thing you will be getting in exam is the celiac disease, Crohn's disease, Whipple's disease. These are three things that are going to be regularly asked. Clear? Very, very regularly asked. This is going to cause mucosal damage. And third point is the one where the problem is the lymph. Lymphatic transport is the problem. So this is the third. So first is the impaired intraluminal digestion. Second is the mucosal damage. And third is the problem in the lymph. Lymph in the sense like the mucosal transport. So first, the lumen. So let me put a diagram so that you will understand much better. It's easy to understand, but First is the lumen. First condition I told you, the problem is the luminal digestion. Second is the mucosa. Third is the transport from the mucosa into the lymph. So third condition, this is where the problem is. First condition, this is where the problem is, lumen. So either in the lumen or in the mucosa or in the mucosal transport into the lymph. So what are the conditions which causes defective mucosal transport? One is primary intestinal lymphangiectasia. Number one. Second is secondary intestinal lymphangiectasia. But these are very rare disorders. You won't get it in exam. And there is also another condition called as IPSID, which causes this mucosal damage. That's called immunoproliferative small intestinal disease, which is typically due to a lymphoma, which can also cause malabsorption. Apart from that, you have heavy chain disorders. So many things are there in this. But nevertheless, there are quite a few things that we need to discuss that, which is important for exams. Pancreatic disorders, Crohn's disease, Whipple's disease, this PRU, and probably IPSID if you have time. So that's all. So these are things we need to discuss in detail. So next, moving on to mixed pathology. So there are conditions which produces mixed pathology, which means they can produce mucosal damage. At the same time, they can produce impaired intraluminal digestion also. For example, you have something called as a SIBO. That's called a small intestinal bacterial overgrowth, which is also a very important question exam. And second is something called a short bowel syndrome, which happens after a massive bowel resection, especially happens after some gastrointestinal surgeries. So short bowel syndrome. And third one is Zollinger-Ellison syndrome due to a gastronoma. In that, what they will be concentrating exam as far as malabsorption is concerned is the SIBO and the short bowel syndrome, which is also very important to discuss. So we are going to discuss malabsorption as a whole, but we are going to give special preference to pancreatic disorders, celiac disease, tropical sprue, then Crohn's disease, Whipple's disease, SIBO, and short bowel syndrome. These are the important topics that we need to know in detail for the exams. Apart from the rest of the things, you can just know the names. They're not going to ask in detail usually because they are very, very, very rare and uncommon in our practice. And we have certain tests that is very, very important. Unless until you know this test for malabsorption, you'll not be able to tell what are the different types, because they'll be asking you about this D-xylose test, and they'll be asking you about like the stool fat. So that qualitative stool fat and quantitative stool fat is there. That is also called a 72-hour quantitative fecal fat. So where you'll use this test and for what malabsorption you're going to use this test. The first is the fat malabsorption. First is for the fat malabsorption. So what are the tests you are going to use for fat malabsorption? For fat malabsorption, you have quantitative tests, which are considered to be the gold standard. Quantitative means you can exactly tell how much fat that's been passed in the stools. And you also have qualitative tests. And you also have other types of tests like semi-quantitative tests and serum tests, breath tests, so many other tests are there. But let us see the gold standard test, that is the quantitative test, quantitative analysis. So in that, the usual question you will be getting in exam is the 72-hour fecal fat. 72-hour fecal fat. So this is the most important, the usual test that is done. So what is abnormal? That is something you need to know. This is considered to be the gold standard test. Remember, more than 7 grams per day. Excretion of fat in the stools is considered to be abnormal, and the test is considered to be positive. So that is a number that you need to know. More than 7 grams per day in a 72-hour fecal fat is considered to be abnormal. There are many methods are there how to estimate this 72-hour fecal fat. And the two methods in biochemistry, they will ask you, one is called as a Van de Kramer method. And second one is something called as a NIRA, that is called near infrared absorptiometry. So currently we prefer using a NIRA, but in biochemistry, they will be, enforcing this Van de Kramer method. Is an old method. So we use NIRA nowadays. That is near infrared absorptiometry or near infrared analysis. So, but nevertheless, what is more important as far as medicine is concerned is the value, that more than 7 grams per day in a 72-hour fecal fat is really, really important. And this is something that's been asked so many times in exam. Okay. Then we have qualitative tests. Qualitative tests in the sense we'll just do a Sudan black staining, or simply we can call it Sudan 3 staining, and we see any fat globules are there in the stools or not. This is a very, very superficial test, not a very good test. So see under the microscope whether there are fat globules that are stained with Sudan black. That is Sudan 3 staining is there. And apart from that, you have some other tests for estimating the fecal fat. That is one is semi-quantitative test. The sense it's both qualitative and quantitative. That's called as acid steatocrit. And they'll be asking you beyond what percentage it is abnormal. If it is more than 31%, it is considered to be abnormal. And next is you have some serum tests are there. Very commonly used nowadays. These are beta carotene in the serum. Usually beta carotene levels will be reduced if there is a fat malabsorption. Then we have some breath tests are there. Breath tests are there. So what is the idea of breath tests is they will be giving some triglycerides that are labeled with radioactive carbon. So they are going to see for the breath that is containing radioactive carbon. Suppose if there is a good absorption of these triglycerides that you are taking, consuming, so that will go into the blood and that will come into the lungs, and that like the radioactive carbon elimination will be increased. Suppose if you have malabsorption, the absorption into the blood from the intestine will be less. So the amount of this radioactive carbon that is going into the circulation and then entering the lungs is also less. So the breath will contain reduced radioactive carbon. That is the idea. So what are the different compounds that we are going to use? So typically, like we are going to label the triglycerides with carbon 14. So what are the substances that we are going to use? We are going to use two substances. One is called carbon 14 triolin. This is a form of triglyceride. And second one, what we are going to use is carbon 14 triactanoin. These are the two substances that we can use. And whenever you consume these two substances, they are going to get metabolized, and the end product of metabolism is carbon dioxide. And this carbon dioxide is the one that will be detected in the breath. Suppose if there is reduced carbon dioxide that is detected in the breath, this test is considered to be positive, and that is suggested to, and the patient is suggested to have a fat malabsorption. I told you the basic already. If you can't absorb, you can't eliminate through the breath, which means you are actually losing a lot of this fat in the intestine itself, in the stools itself. So there's a little possibility of this carbon to be absorbed, and it will be eliminated as carbon dioxide in the lungs. So if you have a reduced carbon dioxide in the lungs, which are labeled with C14, so then in that setting, you can think about a fat malabsorption. This is a breath test, but it's very, very uncommonly used, performed only in expert centers. But right now, the only thing that we commonly do in practice is the 72-hour fecal fat, where more than 7 grams per day elimination of fecal fat is considered to be positive for fat malabsorption. And then we have carbohydrate malabsorption. Carbohydrate malabsorption. As far as carbohydrate malabsorption is concerned, the most important thing that we need to think about is the lactase deficiency. So that is a lactose malabsorption, which is very, very important. How to find out whether the patient is having lactose malabsorption or not? So first, we are going to give 50 grams of lactose to the patient. This is a standardized dose, like 75 gram oral glucose. We are going to give 50 grams of oral glucose to the patient. And after giving a lactose, if the patient is having good absorption, then you need to see increase in the serum glucose, because lactose anyway will be converted to glucose, and then that will be absorbed into the intestine and further into the blood. So you need to find out an increase in the serum glucose. Serum glucose should increase after giving lactose within 30 minutes. So how much it should increase, we have a cutoff. If the increase should be normally by more than 30 to 40, that's the normal increment after giving a 50 grams of lactose in 30 minutes. But if increment in the serum glucose is less than 20 milligrams per deciliter at 30 minutes. At 30 minutes, if you take the serum glucose and the increment is less than 20 milligrams per deciliter from the previous value, at 30 minutes post lactose ingestion, that's considered to be positive for lactose malabsorption. And second thing, you can see the urinary glucose also. Normally, your urinary glucose will increase. But if the urinary glucose does not increase and it is less than 5 grams over a 5-hour period, you are collecting the urine for 5 hours. In the 5 hours, your net glucose excretion in the urine is less than 5 grams, then it's considered to be positive for lactose malabsorption. But nevertheless, we currently don't use this test. Instead, we use certain tests called breath tests for lactose malabsorption, which is considered to be more simple, and the kit is available. That's why. For fat, the kit is very expensive. It is not available in most centers. But for lactose malabsorption, we have a kit, and that's why we use this test. So we have something called a breath hydrogen testing. We use the hydrogen in the breath, amount of hydrogen in the breath. So what happens is, whenever you don't absorb lactose, so you don't absorb lactose in the sense like you will start fermenting the lactose in the intestine, and that fermentation of lactose will produce more hydrogen, and that more hydrogen will be absorbed, and that hydrogen will be excreted in the lungs. So that is called as breath H2. If the breath H2 is more than 20 ppm, it is diagnostic of lactose malabsorption. So the concept is very simple. If you don't absorb lactose, it will be fermented in the intestine. The fermentation will produce more hydrogen. That more hydrogen will be absorbed, and that will be eliminated in the lungs. So if your breath hydrogen is more than 20 parts per million, so then that is supposed to be a positive test for lactose malabsorption. And there could be both false positives as well as false negative. So what could be the reasons for false negative test, and what could be the reasons for false positive test? So this is quite simple to understand. False negative in the sense you do have a lactose malabsorption, but your reports are negative. What is the reason for that? If you're having a lung disease, because this is a breath test that is based on lungs capacity for excretion of hydrogen. If you have a lung disease, even if there is a malabsorption and there is high production of hydrogen, your lungs will not be able to excrete it. So you might be having a low breath hydrogen, which is a false negative test. Or due to heavy antibiotic use. The reason is because if you are using antibiotics, your intestinal bacteria will be killed. If your bacteria is killed in the intestine, even if you have a malabsorption, lactose is still there, not absorbed. It is still there in the intestine without getting absorbed, but the bacteria is not there to ferment this to produce hydrogen. So because of that, you might be having a false negative test. So why is the false positive test? Where you can get false positive if you have too much bacteria in the form of small intestinal bacterial overgrowth. In SIBO, you will have too much of bacteria. Because of that, the fermentation will be more than what is expected. Even for a normal amount of glucose also, there will be too much fermentation. So you might get more hydrogen production than required. So you might result in more hydrogen even if there is no malabsorption. So these are the conditions where you get a false positive test and false negative test, which are very, very important. As far as fat malabsorption is concerned, the current preferred test is the 72-hour fecal fat. As far as carbohydrate malabsorption is concerned, the current test is the breath hydrogen testing. That is the current test that we use after giving a lactose. So third one is something called as a D-xylose test. D-xylose test. So this is a very, very common test that's asked in exam. Very common in the sense so common that's been asked multiple times in the exam. So what D-xylose test does? D-xylose test is basically to differentiate intraluminal disease versus mucosal damage. So when the D-xylose test will be positive, D-xylose test will be positive in patients who are having mucosal damage. In the sense, any patient who's having mucosal disease like celiac disease or whatever here I mentioned, right? So any patients who are having mucosal disease and mucosal damage, they will have a positive D-xylose test. In the sense, like D-xylose test will show some abnormality. That's what I mean. So how will you do a D-xylose test? 25 gram of D-xylose is what something that is given. So once you give this D-xylose will be absorbed and should be absorbed from the small intestine. Typically, it's absorbed from the proximal intestine, but nevertheless, don't worry about that. It will be absorbed from the small intestine. And of course, your serum D-xylose should increase. Serum D-xylose should increase because if there is a normal mucosa, definitely that will be absorbed and the serum D-xylose should increase. If the increment in the serum D-xylose is less than 20 milligrams per deciliter at 1 hour after giving D-xylose, it is considered to be a positive test, which means the patient is having some mucosal damage for sure. Or alternatively, you can see the urinary D-xylose. Urinary D-xylose, like similar to what I've told you for the lactose intolerance, lactose malabsorption, you see the urinary D-xylose. Of course, your urinary D-xylose levels should increase because this will be absorbed from the intestine and it will be going into the blood, which will be filtered by the kidneys, and the urinary D-xylose levels should increase. If the urinary D-xylose levels normally it should increase to more than 5 grams over 5 hours, but if it is less than 4.5 grams over a period of 5 hours of collection of collection of urine, so then it is supposed to be positive. So typically what we prefer in D-xylose, we prefer urinary D-xylose rather than serum D-xylose, which is more prone for errors. The textbooks tell, or any articles, if you take, they tell you can use urinary D-xylose, which is more reliable compared to that of serum D-xylose. So coming from the fat malabsorption, preferred is quantitative 72-hour fecal fat. Coming to the carbohydrate lactose malabsorption, the breath test is the one that is reliable after giving lactose. When it comes to D-xylose test, after giving D-xylose, your urinary D-xylose is more reliable compared to that of the serum D-xylose. The urinary D-xylose urinary D-xylose is less than 4.5 grams over 5 hours of collection of urinary D-xylose, then it is considered to be a positive test which of course D-xylose test when it is positive to indicate mucosal damage. And very importantly, they will be asking you what are the reasons for false negative test and what are the reasons for false positive test. In that, the most important is the false positive. False positive means there will be reduced urinary D-xylose in patients with no malabsorption. This is what we refer to as a false positive test. In the sense, the urinary D-xylose will be low, less than 4.5 gram, despite the patient not having malabsorption. Patient is not having any malabsorption, but still the urinary D-xylose will be low. What are the conditions? I mean, logically speaking, low GFR. When the kidney is not functioning properly, you cannot produce sufficient amount of urine. So you might not be getting a good amount of D-xylose in the urine, even if the patient is not having malabsorption. If the patient is absorbing D-xylose properly, but still your kidneys are not functioning, so you'll have a low D-xylose in the urine. And apart from that, if the patient is having urinary retention, like BPH or any condition that produces severe urinary retention, once again, you're not passing sufficient amount of urine. So that is the reason why they have a low D-xylose. And patients have old age. Old age itself, the GFR, urine amount and all will be less. So because of that, it could be having false positivity. And the patients are having reduced gastric emptying, because it is more based on timed collections. Like you're collecting over a period of 5 hours. In patients who are having slow gastric emptying, they don't have malabsorption, but still just because of slow gastric emptying, the D-xylose will be coming down the intestine very slowly. Absorption rates will be slower. That is the reason if you're collecting for 5 hours, you might not get the correct amount of D-xylose. So in this condition, if you suspect low gastric emptying, you can think about doing extended collections for 6-7 hours maybe. That's given in the textbooks, but nevertheless, this is another reason for false positive test. And apart from that, if the patient is suffering from SIBO, small intestinal bacterial overgrowth, there is too much bacteria in the intestine. In this condition, the bacteria will start fermenting the D-xylose. So the amount of D-xylose that is absorbed actually is less because the bacteria is utilizing the D-xylose. And next is third space loss. For example, if the patient is having severe ascites, the D-xylose may enter the ascitic fluid rather than the urine. So the urinary D-xylose may be lower and the D-xylose can enter the acidic fluid and the pleural fluid. So third space loss is one reason, especially the patient is having massive ascites like liver disease and all. And there are some drugs that reduce the excretion of urinary D-xylose, like for example, NSAIDs, like aspirin, indomethacin, then one anti-diabetic drug called glipizide, and one drug that is used for hepatic encephalopathy, that is neomycin. We have discussed that already. Right now we use rifaximin, but nevertheless, neomycin can result in false positive test. So these are the conditions which result in false positive D-xylose test, especially in the, urinary D-xylose is the one that is reliable, but this is very important to know. So all these things have been asked in exam. So what are the conditions that produce a false positive urinary D-xylose test? In the sense like your urinary D-xylose levels will be low despite the patient not having any evidence of malabsorption. So D-xylose test, very, very important for exam. So any patient with mucosal damage tend to have a low urinary D-xylose. Then as far as B12 malabsorption is concerned, so B12 malabsorption is there. Next, coming to the micronutrient malabsorption. If you have a B12 malabsorption, the patient will have a B12 deficiency. But the gold standard to tell the site of B12 deficiency is Schilling test. But even though we don't use nowadays, it's very cumbersome and has multiple steps. Reproducibility is very less. So that's why we don't use this test nowadays. But gold standard is always the Schilling test to tell the exact problem with regards to B12 deficiency. Or alternatively, simple thing is you can do B12 levels along with homocysteine and methylmalonic acid. Homocysteine and methylmalonic acid. You do all these tests together very commonly. So what will happen? What is the interpretation? If the patient is having B12 deficiency, the B12 levels will be low in the blood, and the homocysteine levels and the methylmalonic acid levels will be high in the blood. If they ask you among all this, the most specific is the methylmalonic acid levels. Remember, homocysteine levels can be elevated in B12 deficiency and folate deficiency. Both will result in elevation of homocysteine levels, whereas methylmalonic acid levels will be elevated only in B12 deficiency. So if at all they ask you among homocysteine and methylmalonic acid, which is specific for B12 deficiency, answer is methylmalonic acid levels, which will be elevated only in B12 deficiency. It will not be elevated in folate deficiency. The details we have discussed already in the hematology chapters, very detailed. So I don't want to tell that again and again. So, but the problem with this B12 homocysteine and methylmalonic acid is it's a general test in the sense like they will tell you B12 deficiency, but they won't tell you the site of problem, whether the problem is in the intrinsic factor or whether the problem is in the like pancreas, or whether the problem is in the terminal ileum. So it will not tell you the site of like damage, and that causes B12 deficiency. So to tell the site of problem in patients with B12 deficiency, you need to do the Schilling test. So Schilling test is done at multiple steps. Schilling test is basically done with multiple steps. You have step number 1. What do you do in step number 1? Step number 1, we are going to give IM B12 first. Why you give IM B12? IM, it's an ordinary B12. It's not a radioactive B12. It's an ordinary B12. This is to saturate the liver, because we don't want the liver to take up B12, and we wanted to saturate the B12 receptors in the liver. Only in the step number 1 we give that. After that we don't give IM B12. Saturate B12 receptors in the liver. Clear? So along with that IM B12, after some time we are going to give oral radioactive B12. Oral radioactive B12. When I write RA, it means radioactive B12. So it will be radio labeled B12 that I'm going to give orally to the patient. Suppose, after this, what I'm going to do is I'm going to check the urinary B12 levels. Urinary B12, that is a radioactive urinary B12. In the sense, like, I'm going to see the radioactivity of B12 in the urine. So urinary B12, radioactive B12 in the urine. Suppose if the urinary B12 levels are increased, sufficient levels are achieved after giving oral B12, which means it indicates a dietary deficiency. It's a very rare scenario. Pure vegans only will have dietary deficiency, but nevertheless, dietary deficiency is common. If the urinary B12 levels are low in this situation, you're going to proceed to the step 2. In the sense, it's not dietary deficiency. Even if you give a oral B12, the urinary B12 is not increasing. So proceed ahead with step 2. In step 2, what I'm going to give is I'm going to administer intrinsic factor. Plus, along with that, I'm going to give oral radioactive B12. Oral radioactive B12. Now check again the urinary B12. If the urinary B12 is increased in this situation, then it is suggestive of pernicious anemia. Why pernicious anemia? Because in pernicious anemia, you will have deficiency of intrinsic factor. Because of that, you are having B12 deficiency. So if urinary B12 is increased after giving intrinsic factor, and if it is corrected, then it is suggestive of a pernicious anemia. If the urinary B12 levels are still low, which tells you that the patient is not having pernicious anemia and the problem is not due to pernicious anemia. So you need to proceed ahead with step 3 in this scenario. What is step 3? Now you are going to administer antibiotics, a course of antibiotics. Along with that, you are going to give oral radioactive B12. And after this, I'm going to check the urinary B12. In this situation, if the urinary B12 is increased, that is suggestive of small intestinal bacterial overgrowth, because when I give antibiotics, the bacteria will be killed in the intestine. So any overgrowth of bacteria will be corrected. So because in SIBO, the bacteria will consume B12, and that is the reason for B12 deficiency. So once I give antibiotics, that should be corrected. That is the idea. So if the urinary B12 is still low, then I can go for step 4. Step 4. In step 4, what I'm going to use, I'm going to supplement pancreatic enzymes. Then I'm going to suspect pancreatic enzymes. If deficiency of pancreatic enzymes. So if I supplement pancreatic enzymes, along with that, I'm giving oral radioactive B12. Now, once again, I will check the urinary B12 and its radioactivity. If the urinary B12 levels are increased after supplementing pancreatic enzymes, so it indicates an exocrine pancreatic insufficiency. Because pancreatic enzymes are also important for absorbing B12. If you take the B12 absorption physiology textbooks, this separation of the intrinsic factor, separation of the R binder, for that you need this, like pancreatic enzymes to an extent. So pancreatic enzymes are also important. If you don't have heparin pancreatic enzymes, you will not be able to absorb B12 properly. So the suggestive of exocrine pancreatic insufficiency. Suppose if the urinary B12 levels are still low, in this setting, it's not dietary deficiency, it's not pernicious anemia, it's not pancreatic insufficiency, it's not SIBO, it is something else. For example, usually this condition where everything failed, you will come back to terminal ileal disease. some terminal ileal disease is there. So which means you are thinking about probably a tropical sprue, or probably it could be a Crohn's disease, or it could be a celiac disease, or it could be intestinal resection, distal ileal resection after surgery. So that could be the possibility. So it indicates a ileal disease, that's all. So if all the steps fail and still your urinary B12 is not increasing, you suspect a ileal disease. These are the different steps of Schilling test. Like even though it is a cumbersome test, not easily done, not easily reproducible, it's not a very good, in the sense like in reality, you can't do this test, but this is supposed to be the gold standard to tell the exact problem or site of problem in patients with B12 deficiency. So first step, you're going to give oral B12 to rule out dietary deficiency. Second step, you're going to add intrinsic factor to the oral B12 and check for urinary B12 to test for pernicious anemia. Third step, you're going to supplement with antibiotics to rule out SIBO. And fourth step, you're going to give pancreatic enzymes and test again. If all these 4 steps fail to increase urinary B12, then you can think about the possibility of ileal disease. So this is what we refer to as Schilling's test, and it's one of the important gold standard tests. Remember, all these are important. Intrinsic factor is important. Then pancreatic enzymes are important. Then distal ileum is important. So these are the 3 key things that are important for absorbing B12. So if there is problem in any of this, then you will result in a deficiency of B12. That's all. Apart from dietary deficiency. Dietary deficiency means you're not taking sufficient amount of B12. But B12 deficiency is common in vegans, especially. We call vegans. Vegans in the sense like those who don't take any animal related diet at all. They never take animal related foods. In the sense like it's a pakka complete vegetarian diet. It's not just a vegetarian diet. A vegetarian diet includes dairy products also, but these vegans will not eat any animal related food. In the sense like they don't eat anything that comes from animals, including dairy products. So if you don't eat any animal related products, you will end up with a B12 deficiency. That's for sure. So that's why vegans have a high risk of developing B12 deficiency. Then followed by vegetarians, rarely non-vegetarians. Non-vegetarians generally don't develop dietary B12 deficiency. Vegetarians also don't really develop dietary B12 deficiency unless and until they don't consume sufficient amount. Vegans, very commonly, they end up with B12 deficiency because they don't eat any animal related products, which is the only source of getting B12 from the environment. So this is Schilling test. So very important test for exams. They'll ask you all these steps in exams for sure, but in reality, we don't perform this test. Do you understand this Schilling's test? Do you understand or not? Schilling's test, so that we can move on to the next one. Clear? Okay, cool. So this is how you do a stepwise Schilling test. Fine. So then we have tests for bile acid malabsorption. So we have discussed on what all we have discussed. We have discussed on 4 things. One is fat, carbohydrate, D-xylose, and B12. And 5th one is the bile acid malabsorption. Bile acid malabsorption. So this is a very common test. What is the test that is used? That is called HCAT scan. So selenium HCAT, otherwise simply called a SACAT scan. So this is the test of choice for diagnosing B12 malabsorption. Clear? So then we have protein malabsorption. But this is something that is not done routinely, but you can actually test. So there are some tests for protein malabsorption. Like for example, you have alpha antitrypsin clearance is there. Alpha antitrypsin plasma clearance test. So just know the names. That's more than enough. Alpha antitrypsin plasma clearance test. Then we have technetium 99M based test like technetium 99M albumin scintigraphy infusion. We'll give technetium 99M albumin infusion and detect by scintigraphy to see the loss of leakage of albumin in the intestine. So we can tell where the leakage of albumin is happening in the intestine. So that's called technetium 99M albumin scintigraphy, and it's given as an infusion. Then we have something called C-octanoic acid radiolabeled carbon octanoic acid, and we can use radiolabeled carbon egg white analysis or urinary phenol and cresol measurement. And this is only for research purposes. And we also have this fecal nitrogen estimation. Fecal nitrogen estimation. Like blood urine nitrogen, we have fecal nitrogen. So these are rare tests we don't do really. So that's why I'm telling at the last. So these are something that is mostly used for only research purpose and experimental purposes. We're not going to really use any of this test. But this is something that's asked very commonly in exam. If they ask you what is the test of choice for detecting bile acid malabsorption, then of course you need to answer this SECART scan, selenium 75 HCAT scan. No need to worry about that. Clear? They won't ask the numbers. So we have discussed on the tests. So fat quantitative is the most important. That's what we are using. 27-hour fecal fat more than 7 grams per day is the positive test. As far as lactose intolerance is concerned, the breath test is very important. That is hydrogen more than 20 ppm is suggestive of lactose malabsorption. And as far as D-xylose test is concerned, unit D-xylose excretion less than 4.5 gram over a period of 5 hours after giving 25 grams of D-xylose is the test for, mucosal integrity. So it tells you that the mucosa is damaged. In B12 malabsorption, you typically test for B12 deficiency, but to tell the site you need Schilling test. I told you all the 4 steps of Schilling test. And finally, bile acid malabsorption, selenium 75 SECART, and protein malabsorption, you have a variety of tests, none of which is practical right now. All right. Apart from that, you have pancreatic function tests are there. In chronic pancreatitis, you can test for pancreatic function. You can test for SIBO. That's a separate breath test is there for small intestinal bacterial growth, which will be discussed later on. And what are the roles of endoscopy? Endoscopy biopsy. Will endoscopy and biopsy will be able to tell you the diagnosis, or it will not be able to tell you the diagnosis? So, number one, there are certain conditions where endoscopy is considered to be diagnostic, in the sense you can easily tell that this is the problem. Without even looking at any other tests, you can clearly tell that this is the problem that the patient is having just with endoscopy and biopsy. First one, they will ask you about the Whipple's disease. It's very, very important. In Whipple's disease, you are going to see this past-positive diastase resistant macrophages. Remember, Whipple's disease is AFB negative. So they'll be past-positive diastase resistant, but AFB negative. So if you see these macrophages in the intestinal wall, that is definitely Whipple's disease. There's no other diagnosis that is possible. So that's why endoscopy is diagnostic in this scenario. Second is MAC, Mycobacterium avium complex enteritis, especially in disseminated MAC complex infection, especially MAC, Mycobacterium avium complex enteritis you can get. So remember, MAC enteritis will show past positivity. At the same time, there will be AFB positive. So that's why I told you that all past positive are not Whipple's disease. MAC enteritis can also be past positive, but clearly examiners will tell that the macrophages and the AFB stained bacterium will be seen. So AFB positivity is also a key feature here. And third is the A-beta lipoproteinemia. In A-beta lipoproteinemia, as I told you, they cannot form chylomicrons. So whatever fat they are absorbing, they cannot package into chylomicrons and put it into the lymph. So these fat globules will be accumulating within the intestinal cells, that is the enterocytes. So these are called as lipid-laden enterocytes, which I'll show you in some time. Lipid-laden enterocytes. So these are very classic of A-beta lipoproteinemia. Let me show you the images. You can see the images here. The first one is the Whipple's disease. In Whipple's disease, typically, you will see this past positive staining. For example, there is a control here. These are the normal macrophages that you're seeing here. But in patients with Whipple disease, you can see this macrophages will contain this past positive substances. You can see everywhere, you can see this in past staining, you can see this some past positive substances, some granular substances are there inside the macrophages. So this is past positive macrophages, very classical of Whipple's disease. And second is the lipid-laden macrophages. And one more clue in exam, they will give this acanthocytes in the peripheral smear. Along with that, if they give evidence of malabsorption, along with that, if they give a picture like this, where there are so much of lipid droplets within the enterocytes, so that is suggestive of A beta lipoproteinemia. So this lipid-laden macrophages with the peripheral smear showing acanthocytes and patients having malabsorption, typically think about A beta lipoproteinemia. Whenever they give past positive macrophages with malabsorption, think about Whipple's disease as a possible diagnosis. This is the most important. These are 2 points. So, which means there are areas where endoscopy is diagnostic. Second condition, endoscopy may be diagnostic in the sense like these disorders are patchy. That's the problem. In the sense like if you miss those areas from taking a biopsy, you might not end up with the diagnosis. So, which means they may be diagnostic, but the problem is their involvement is patchy. But here, diagnostic means their involvement will be diffuse. Because the involvement is diffuse, anywhere you take a biopsy, you're going to get a positive result. But maybe diagnosed in the sense like if you find out, it's good, but sometimes you may not find out because the lesions are patchy. You might miss these lesions. For example, intestinal lymphoma. It will happen only in one area. So it's very difficult to sometimes biopsy accurately unless until you have imaging evidence. So sometimes it might be missed. Primary and secondary intestinal lymphangiectasia. Unless until you see this properly, you will miss out easily because this is a very, very patchy lesion. So that's why it is missed. So that's another condition which may be diagnostic, but because it's patchy, you might miss them. And eosinophilic enteritis. You might miss it because the lesions are patchy more towards the distal where endoscopy may not reach that places. And systemic mastocytosis, again patchy lesions, you might miss. Amyloidosis, once again patchy lesions, you might miss easily. Crohn's disease, it's known for skip areas, very commonly studied from the second year time. Crohn's disease is patchy, skip areas will be there, you might miss. And gyardiasis. I mean, gyardiasis you can definitely diagnose through biopsy if you see the trophozoites in the lumen, but because the lesion is patchy, sometimes you might miss that place. So it might go off. Or next is something called coccidiosis. Coccidiosis, which can be due to either cryptosporidiasis or it could be isosporiasis, isospora belli. Clear? So you might miss these things out because they are patchy. But if you find out that trophozoites of Giardia or probably this, like coccidial forms of cryptosporidium and isospora, then definitely you can make a diagnosis. But because the lesions are patchy, sometimes you may not be able to take the biopsy properly. Remember, as far as cryptosporidium is concerned, the organism will be seen on the surface of the intestinal epithelial cells. But as far as isospora is concerned, it will be seen within the surface. Sorry, within the cells. Within the cells, inside the cells. The organisms will be seen inside the cells. For cryptosporidiasis, the organisms will be attached to the surface of the cells, intestinal epithelial cells, whereas for isospora, the organism will be seen inside the cells. So this is the clue to differentiate between cryptosporidium and isospora in biopsy. Apart from that, there are conditions where endoscopy and biopsy is completely non-diagnostic. One is celiac sprue, second is tropical sprue. Very, very important. You cannot diagnose based on endoscopy because the findings that you see in endoscopy and biopsy may be seen in many other conditions. Like for example, let me show you the biopsy of celiac disease. There are two classic hallmarks of celiac disease. One is the loss of this villi. You can see this villus projections here. You can see these are the villus projections that we are talking about. So you won't see the villi. Loss of villi will be there. And you can see this. These are the crypts that we are talking about, and they'll be hyperplastic. So the second thing what you're seeing is crypt hyperplasia. And third is you can see lots and lots of blue are there. These are increased intraepithelial lymphocytes. These are three classic features of celiac disease. One is loss of villi, second is crypt hyperplasia, and third is increased intraepithelial lymphocytes. Number one, loss of villi, crypt hyperplasia, increased intraepithelial lymphocytes. These are the three classic hallmarks of celiac disease. If you ask me whether this is specific for celiac disease or not, absolutely no. This can be seen in a variety of conditions, including tropical sprue. So this is not at all specific for celiac disease. And endoscopy, what are going to see in celiac disease? In endoscopy, you're going to see something like this, but this is also again not specific for celiac disease. So what you typically see is something called a scalloping of the intestinal folds. You can see this is a normal intestinal fold, but in celiac disease, you can see this kind of scalloping and see small excavations here. These are what we call the scalloping of the folds, intestinal folds will be there. So this is again suggestive of celiac disease, but it's not confirmatory for celiac disease. In the sense, like these findings are non-diagnostic. So don't think that if you get this, it's 100% celiac. It is non-diagnostic. It can be seen in many other conditions, including viral gastroenteritis. In acute viral gastroenteritis, that time if you do a biopsy, you will see all these findings: scalloping of the folds, uh, villus atrophy, crypt hyperplasia, increase intraepithelial lymphocytes. All these things can be seen in viral gastroenteritis also. Or it can be seen in patients who are having intraluminal bacterial overgrowth, that is SIBO, small intestinal bacterial overgrowth, can also have similar feature. And patients who are having radiation enteritis, radiation-related damage, can have same features: crypt hyperplasia, increased lymphocytes. All these things can be seen in villus atrophy. All these things can be seen in radiation enteritis also. Or simple folate and B12 deficiency, even without any pernicious anemia, simple folate and B12 deficiency also can produce all this features. So which means whenever you find these features in exam, you might think about celiac disease, but in general, endoscopy is non-diagnostic. You should be very careful in that. So most of the times, what will be your exam question? So this is going to be your exam question most of the time. So where the endoscopy is diagnostic, that is where they ask. And the most important thing they will be asking is Whipple's disease and A-beta lipoprotein. These are the two things that they have regularly asked in the previous exams. Like in 2015-16, if you ask, there will be one question on this for sure. But in 2018 onwards, they didn't ask much, but still it's worth knowing. So what are the areas where endoscopy is diagnostic? What are the areas where endoscopy may be diagnostic? And what are the areas where endoscopy is non-diagnostic? In that, the most important is going to be celiac disease and tropical sprue, which cannot be differentiated 100% by endoscopic assessment alone. So you need to have multiple other diagnostic standpoints. So let us put everything into perspective. So let us assume a patient who's having a luminal issue, a patient is having a mucosal damage, a patient who's having a lymphatic obstruction. That is, mucosal transport is the problem. So luminal issue, mucosal damage, lymphatic transport issue. So what's going to be the different, how the different investigations are going to play a part. So one is stool fat, that is quantitative stool fat. In patients who are having impaired intraluminal absorption, it will be increased. In patients who are having mucosal disease, also will be increased. In patients with lymphatic obstruction, will be increased, which means invariably any condition that produces malabsorption will produce steatorrhea, which means it is going to have increased stool fat or increased fecal fat. But how much the fecal fat also can give you a clue. So in luminal problems, it will be very, very high. It will be more than 9.5 grams per day. Whereas in mucosal disease, it will be increased, but not to that extent. It will be less than 9.5 grams, but still it will be more than 7 grams per day, but will not be elevated to that extent. So the maximum increment in the stool fat will be seen in patients who are having luminal disease. The best example for luminal disease is pancreatic disease, where there will be loss of pancreatic enzymes. Because of that, you will have maximum steatorrhea seen in patients who are having impaired luminal digestion of fat. Second is fecal elastase. Elastase in stool. This is called fecal elastase testing. This is also an alternative to, like this stool fat, especially in patients with pancreatic disease. Remember, this fecal elastase is decreased only in patients who are having luminal disease, but at the same time, it happens only in patients who are having pancreatic disease, exocrine pancreatic insufficiency, only in those patients, because elastase is something that is coming from the pancreas, exocrine pancreas. So this fecal elastase is less. It tells you more specifically it's a pancreatic disease. That's all. But it will be normal in other conditions because pancreas produces elastase. Reduced fecal elastase means it's a pancreatic disease, exocrine pancreatic insufficiency. So increased stool fat, 72 hour stool fat with reduced fecal elastase is equal to pancreatic disease. That's all. Third is serum creatine. Serum creatine levels. As I told you, because of malabsorption, creatine will not be absorbed. And in all these three situations, serum creatine will be reduced because creatine will not be absorbed if there is a fat malabsorption. And what about serum cholesterol? Serum cholesterol may be reduced in all these three situations because of fat malabsorption. And then we have something called as serum albumin. Serum albumin. Remember, serum albumin will be normal in patients who are having intraluminal disease. But one area where serum albumin may be decreased is SIBO, where it will be decreased. But apart from that, in most of the situations, serum albumin will be normal. But in other diseases, impaired mucosal transport or mucosal damage itself, your serum albumin will be typically low. There will be hypoalbuminemia, which is the common thing that you see in the setting of malabsorption. Serum calcium. Serum calcium, once again, it will be normal here, but it will be decreased in mucosal damage and luminal transport. I mean, problems in the mucosal transport, lymphatic issues. So, but it will be normal in patients who are having luminal disease. And vitamin D. Usually we do something called calcidiol testing. That's a common test that we do. Calcitriol is not tested in reality. Calcidiol, that 25-hydroxy cholecalciferol is the one that is tested. Vitamin D in general will be decreased in all these three disorders. Okay. Then we have serum iron. Iron will be normal in patients who are having luminal disease. Again, normal in patients who are having transport-related problems, but definitely decreased in patients who are having mucosal damage. So you can think about celiac disease, which is a typical problem of mucosal damage. So definitely patients will have reduced iron absorption, patients who are having celiac disease. And serum folate. What about folate? As far as folate is concerned, once again, it will be normal here, decreased here, normal here. As far as micronutrients is concerned, everything is going to behave in the same way. And next, we can go to the Schilling test. As far as Schilling test is concerned, it will be abnormal in patients who are having intraluminal disease because pancreatic enzymes are very, very important for absorption of B12. And next, in mucosal disease, again, it will be abnormal because terminal ileum, I told you, is very, very important for absorbing B12. It will be abnormal. But patients who are having abnormalities in mucosal transport, like lymphatic obstruction, will have a normal Schilling test. They don't have any abnormal Schilling test. They'll absorb radioactive B12 pretty easily. And next is lactose intolerance, lactose absorption. Lactose absorption, it will be normal in patients with intraluminal issues because fat is the most important problem in pancreatic disease. Carbohydrates okay, especially lactose is fine. So it will be because intestine itself secretes lactase, so they can absorb lactose pretty easily. But one area where it will be abnormal is in SIBO. I told you in SIBO, the lactose will be fermented by the intestinal bacteria, so they'll produce more hydrogen. So there will be a false positive, increase breath H2. There will be a false positive test in small intestinal bacterial overgrowth. But apart from that, in intraluminal disease, it will be normal only. In mucosal disease, it will be definitely abnormal, which means lactose absorption will be reduced. So there will be reduced breath hydrogen. And at the same time, in lymphatic issues, you don't have any problem because lymph obstruction is more important for fat again. For lactose, it's not that important. And apart from that, we have the D-xylose test, which we have discussed. As this D-xylose test is concerned, I told you it's a test of mucosal integrity. In the sense, it tests the mucosa. So it will be normal in patients who are having luminal disease, and it will be normal in patients who are having lymphatic obstruction. Only in patients who are having mucosal damage, they'll be having abnormal test. So remember, D-xylose is a test of mucosal integrity. So it will be abnormal only in patients who are having mucosal disease. In other areas, it will be completely normal. And as far as antibodies are concerned, serology, autoantibodies are concerned, antibodies are generally negative in these conditions. Usually it will be positive in mucosal disease. Best example is celiac disease, where you will have an antibody called anti-trans tissue glutaminase Ig antibodies or anti-endomysial antibodies. This will be positive in celiac disease. So you can get autoantibodies positive in mucosal damage. And next is endoscopy and biopsy. Endoscopy and biopsy will be normal in these settings. It will be abnormal, definitely, in patients with mucosal disease, and definitely will be abnormal in patients with lymphangiectasia, that is lymphatic obstruction. Surely, if you take the right biopsy. But remember, it can be diagnostic or may not be diagnostic. That is different. I'm talking about whether it can be diagnostic or may not be diagnostic. That is not the issue here. But it will be abnormal. So what I'm trying to tell is that abnormality may be diagnostic or may not be diagnostic for a particular disease. But in mucosal disease, And in patients who are having lymphatic obstruction, definitely very likely they'll be having abnormal endoscopy. Some abnormality you can expect in the endoscopy. So this is the final table that you need to know, which is very, very important. But what are the few things that are very important? Remember, even though steatorrhea is a common feature of all malabsorption, the maximum steatorrhea seen in luminal disease like pancreatic issue, elastase will be decreased in patients with pancreatic disease. So whenever you have an increased stool fat with reduced elastase, it is typically diagnostic of exocrine pancreatic insufficiency in exams. Clear? And more importantly, they will ask you about the D-xylose test. D-xylose test is completely normal in patients with pancreatic insufficiency. Very, very important point. So in exam, if you get a high stool fat, low fecal elastase, and a normal D-xylose test, what they're trying to tell is it's a pancreatic disease. Very, very, very common question in exam. Very, very common. One of the very, very important questions. And apart from that, Schilling test in pancreatic disease will be abnormal. There is no question about that because pancreatic enzymes are important for absorbing B12. So Schilling test will be abnormal. So these are the four things that you need to know as far as pancreatic disease is concerned. As far as mucosal disease is concerned, the most important, thing about mucosal disease, the D-xylose test will be abnormal. So that, in fact, D-xylose test will be abnormal only in patients with mucosal disease. That is why this is a very, very important point. All the other conditions, apart from mucosal disease, D-xylose test will be normal. So if they give D-xylose test, you are dealing with a mucosal problem like celiac disease or a tropical screw, something you're dealing with. And what else is very, very important? Yeah, that's all. And Schilling test will be normal in patients with lymphatic disease. So this is something that might be asked in exam. They have not asked till now, but it might be asked in exam. So if you want to have a take home of the entire table, what I have given, all the points are important, but if you want to have a take home, they'll ask you about pancreatic disease and celiac disease only. So pancreatic disease, a normal D-xylose, celiac disease, an abnormal D-xylose. Pancreatic disease will have a high stool fat, in fact, a very high stool fat with low fecal elastase and a normal D-xylose test, and they will be having an abnormal Schilling test. In a celiac disease patient, you will have a high stool fat, but will not be very, very high like pancreatic disease. There are normal fecal elastase, abnormal D-xylose, and abnormal Schilling test. So this is how you tell it's a celiac disease. This is the final take-home point. Clear? So do you understand what I'm trying to tell so that we can move on to the next discussion on malabsorption, that is on celiac disease. Do you understand? So we're going to discuss on celiac disease next. Celiac disease is very, very important topic for your exam. Okay, I think I'm getting some answers which are telling yes. So we can move on to the next one. Okay, celiac disease. So there are quite a few points that you need to know about celiac disease. So that's the next thing we are discussing, basically. So there are a few points that are important in celiac disease. Celiac disease is a very common question in exam, but most of the times your diagnosis will be based on the D-xylose test and all these things. But there are some points that are important. Number one, the genetic predisposition. Genetics in celiac disease are something that is very commonly asked. So what are the genetic predisposition? So one is the HLA association, HLA-DQ2, HLA-DQ8. Both are very, very important. This is the most common association, HLA-DQ2, which is seen in almost 90 to 95% of the patients. HLA-DQ8 is seen in the remaining 5 to 10%, which means almost all the celiac disease patients will have some HLA, at least DQ2 or DQ8 will be there in almost all of the celiac disease individuals. But the vice versa is not true. All patients who are having DQ2 or DQ8 may not have celiac disease, but anyone with celiac disease will have DQ2 or DQ8. So it's like that kind of an association. So remember, anyone with DQ2 or DQ8 may not have celiac disease. In the sense, like DQ2, DQ8, if I have, it doesn't mean I should get celiac disease. But if you take a patient with celiac disease, they will surely have a DQ2 or DQ8. So that's why this is very important. Genetic predisposition. So the HLA is the very important genetic predisposition. And what is the site of pathology? And usually, who are the ones that are affected? Usually, females are the ones who are going to be typically affected from celiac disease compared to males. Of course, most of the autoimmune disorders will be common in females compared to males. And people of Caucasian descent are the ones who are more prone for celiac disease compared to Indian descent. In India, finding out a celiac disease is actually quite rare. You might end up with getting a celiac disease, but in general, getting celiac disease in India is not that common unless you are working in a tertiary care center where you might see a few cases of celiac disease. But in Caucasian population, when you go to Europe, especially in Northern Europe, you can see a lot of celiac disease patients, which is very, very common there because HLA, DQ2 and DQ8 is very, very common in that population only compared to Indian subcontinent. And which is the site of pathology in celiac disease. Remember, the entire intestine can be affected in celiac disease. In the sense, like small intestine I'm talking about, stomach, colon will not be affected in celiac disease. In fact, the entire intestine can be affected in celiac disease, but the usual site of pathology is the proximal intestine. Proximal small intestine is what I'm talking about. Proximal small intestine. This is the usual site of pathology as far as celiac disease is concerned. Typically, the duodenum. Duodenum is one of the first and the worst affected areas in celiac disease. That is why most of the patients will have iron deficiency anemia and hypocalcemia, and in fact, even vitamin D deficiency. Very common in celiac disease patients. So, proximal intestine is affected, and duodenum is the commonest area that is affected in the celiac disease patients. And as far as age is concerned, we talked about females, but what age group are generally affected with celiac disease? In general, it has something called as a bimodal distribution, like Hodgkin lymphoma. This is a disease that has bimodal distribution, like myasthenia gravis. So, you can tell some disorders which have bimodal distribution. One example is celiac disease. The first peak will happen at around 8 to 12 months of age in the infantile age group, where there will be first time exposure to gluten-related diet. That is the time where they wean the breast milk and they start giving the like supplementary feeds, and that time they will start introducing gluten into the diet, and that time you might notice the child is having celiac disease. Second one is in the young adult age group, like 20 to 40 years of age. This is young adults. This is the most common age group where celiac disease is diagnosed. First one is 8 to 12 months and second one is around 20 to 40 years of age. So it's a bimodal disease, but most commonly it is found around 20 to 40 years of age. But remember, celiac disease can happen at any age, but commonest age group is 20 to 40 years of age. Okay. So then we have, some gluten-related disorders which you need to know. Remember, the most important point that you need to know is all gluten-related disorders are not celiac disease. So why I will tell you? Because there are a variety of gluten-related disorders, and all gluten-related disorders are not celiac disease, which means if you have a gluten allergy or gluten hypersensitivity, that doesn't mean it's celiac disease. Celiac disease means there should be evidence of autoimmunity. So remember, first of all, you can divide into autoimmune gluten-related disorders, and second one is non-autoimmune gluten-related disorders, and third one we have something called simple wheat allergy. This non-autoimmune gluten-related disorders and wheat allergy are basically not celiac disease. So typically this non-autoimmune gluten-related problem we called as a non-celiac gluten hypersensitivity. Gluten hypersensitivity, which means they can present with same symptoms and signs of celiac disease, but they will not have any evidence of autoimmunity. So which I'll come back to that in some time. As far as wheat allergy is concerned, it's a basically type 1 hypersensitivity reaction. They present like allergy, wheals, urticaria and all these things. So that is typically called as wheat allergy. That is completely different disease and it's not really celiac disease. And apart from that, as far as autoimmune disorders are concerned, the most important is going to be the celiac disease, which will have antibody association. And apart from that, there is something called gluten ataxia. And there is a third problem, that's a skin problem. That is called as dermatitis herpetiformis. That's called DH, dermatitis herpetiformis. Celiac disease may or may not be associated with this disorder, which means these disorders like dermatitis herpetiformis and gluten ataxia can happen without celiac disease also, or they can come along with celiac disease also. So you cannot predict that. But celiac disease is a completely separate differential diagnosis. Please understand, when you have a celiac disease, typically you have a long history. In the sense, very long history you will have. Very long history. In the sense, like you might be having history of months to years most of the time. So long history is very common in celiac disease patients. And antibodies will be positive typically in patients with celiac disease, especially anti-TTG IgA. That's what we're talking about. So that anti-TTG antibodies or anti-endomysial antibodies will be positive, and there will be enteropathy, which means in endoscopy you can see this enteropathy. You can see the villus atrophy. All these things you can see, but symptoms can be either intestinal symptoms or extraintestinal symptoms. Intestinal symptoms and extraintestinal symptoms both will be there in patients with celiac disease. As far as when it comes to non-celiac gluten hypersensitivity, usually there will be a very short history, in the sense like only hours to days. It will not have a very long history, only short history will be there. Antibodies will be negative. You don't end up with getting antibodies, and there will be no enteropathy. In the sense, when you do endoscopy and biopsy, you will not get any enteropathy. I mean, any abnormality. The endoscopy biopsy will be completely normal. Symptoms, still it can be intestinal symptoms as well as extraintestinal symptoms. The intestinal symptoms what you get will be almost the same as that of what you get in celiac disease. It will be indistinguishable from celiac disease. That is why, based on symptoms, you cannot diagnose celiac disease. Celiac disease is a diagnosis of a multimodal approach. You need to have antibody positivity, you need to have endoscopy positivity, you need to have intestinal symptoms and improvement with what is that? When you remove the gluten from the diet, so they should have improvement. So all these things should be there. Then only you can diagnose celiac disease. So celiac disease is not a diagnosis of symptoms, or celiac disease is not just a diagnosis based on some antibodies. You need to have a comprehensive analysis, and you need to have a multimodal approach. So many things should be there to make the possibility of diagnosis of celiac disease. And it comes to wheat allergy, once again they'll be having a short history, and you don't develop antibodies, you don't have antibodies, and you don't have enteropathy here also. And once again, you can get symptoms which can be intestinal symptoms as well as extraintestinal symptoms. And once again, the intestinal symptoms you get in patients with wheat allergy can be indistinguishable from celiac disease, which means you might get the same symptoms like diarrhea, bloating. All these intestinal symptoms may be completely similar to that of celiac disease. So you cannot make a diagnosis of these three disorders if you are making a diagnosis based on symptoms only. You need to work up on antibodies. You need to do an endoscopy and biopsy also. These are things that will definitely tell you whether it's a celiac disease or not. Then what about the coexisting conditions? Coexisting conditions usually will be there, like other autoimmune disorders like myasthenia gravis, vitiligo, Hashimoto's thyroiditis may be there in patients with celiac disease, which will be definitely not there in patients with coexisting conditions will be absent in non-celiac gluten hypersensitivity and wheat allergy. And apart from that, complications, long-term complications are very, very common in patients with celiac disease if they don't adhere to gluten-free diet. But long-term complications will not be there in patients with non-celiac gluten hypersensitivity and patients with wheat allergy. And similarly, HLA DQ8 and DQ2 may or may not be there. As I told you, HLA DQ2 and DQ8 may be there in me also, but I may or may not develop celiac disease. So which means in same applies here also. Patients with non-gluten hypersensitivity or non-celiac gluten hypersensitivity and patients who are having wheat allergy may have HLA DQ2 DQ8, but that doesn't matter. Remember, DQ2 DQ8 is having high sensitivity but has no specificity, which means if I add DQ2 DQ8, you cannot be sure that I have celiac disease. But any patient with celiac disease will have DQ2 DQ8. That's why I told you they have higher sensitivity, but the specificity is poor, which means if you cannot diagnose celiac disease based on DQ2 DQ8. So it can be seen in patients with other conditions which I have described also. So this is something which is very, very important to know. So what about celiac disease? Celiac disease is a condition where there will be antibody, there will be an enteropathy that can be diagnosed by endoscopy and biopsy, and there will be coexisting conditions. May or may not be there, but usually will be there. And the long-term implications are too much, and they will develop a lot of complications if they don't adhere to gluten-free diet. But the problem is the symptoms, especially the intestinal symptoms, are not specific for celiac disease. It can happen in any other condition also. So you need to know about all these things. So in general, in exam, they'll ask you about dermatitis herpetiformis also. You know very well. So it's an IgA related disorder. Everyone knows that. So usually this is a condition that comes with intense pruritus. Especially they will be having some vesicular and bullous lesions, bullous rash, typically in the elbows. Can happen anywhere in the body, but typically in the elbows. And investigation wise, the gold standard investigation is biopsy. You need to do a skin biopsy where you'll be seeing the IJ deposition in the dermis, on top of the dermis, in the tip of the dermis. In the tips of the dermis, you'll be seeing IJ deposition. And treatment is gluten-free diet. Because it's a disorder of gluten, so you have to give gluten-free diet, plus you need to give dapsone. Dapsone is considered to be the most important drug, and it produces, typical dramatic response in patients with dermatitis herpetiformis. This is something that's very commonly asked in exams as well, dermatitis herpetiformis. It is all related to gluten hypersensitivity, but please understand, patients with gluten ataxia and patients with dermatitis herpetiformis may or may not be associated with celiac disease. Some patients with dermatitis herpetiformis may have underlying celiac disease, but some patients with dermatitis herpetiformis may not have celiac disease and they will be having only skin disease, that is dermatitis herpetiformis. So this is a wide view. It's a bird's eye view of different gluten-related disorders. So why I told you this is because all gluten-related disorders are not celiac disease, and all celiac disease, in the sense, are not happen in the same way like other disorders. It can be different. So in the sense, if you want diagnosis like this, one more time I'll tell you, you need to have a long history, antibodies will be there, and enteropathy will be there, which can be diagnosed by endoscopy biopsy. And long-term implications are great if the patient don't adhere to gluten-free diet, and the patients will be having a lot of coexisting conditions if you're lucky enough to find. But the symptoms are not enough to diagnose celiac disease, which can be seen in multiple other conditions, which is what is very, very important. And when it comes to celiac disease, the most important problem is the gluten. So what is this gluten basically? So remember, typically when you take gluten, so you have two key components are there in gluten. So one is called as glutenin. So you can talk about one is called as glutenin. Glutenin is one component, and second component in gluten is the prolamins. Prolamins are the second component. As far as prolamins is concerned, there are two types of prolamins. One is called gluten prolamins, gluten-related prolamins, and second one is called as non-gluten prolamins. Non-gluten prolamins. Basically, as far as gluten is concerned, in the gluten, these prolamins are the ones that are considered to be problematic. Prolamins are the ones that are considered to be problematic. And of course, the gluten prolamins are more problematic compared to the non-gluten prolamins. So where you see this non-gluten prolamins are typically seen in maize, corn, then rice, then you have millets, then you would have studied sorghum. So these are the things that has something called non-gluten prolamins. Since non-gluten prolamins are not dangerous, they are considered to be absolutely safe in patients with gluten hypersensitivity and even in patients with celiac disease. They are considered to be absolutely safe. You can take this, not a problem at all. But as far as gluten prolamins are concerned, so there are two groups again. So one is the oats. Oats associated prolamins are called as something called as avenins, which is also a type of prolamins only. But whether they are safe or not, it's quite controversial. Some textbooks tell it's safe, some people tell it's not safe, but we really don't know whether it's safe or not. These oats may or may not be safe, we don't know. But there are some group called Triticeae. Triticeae tribe, because this particular plants are actually basically seen in the civilization from the Triticeae tribe. So what are these group which contain this typical non-safe compounds? Like for example, you have wheat, and the typical prolamin that is found in wheat is called as gliadins. And the typical prolamin that is seen in another compound called plant called rye is something called as sicalin. And the third one, we have something called barley, which contains something called hordin. And all these are considered to be completely unsafe. In patients with gluten hypersensitivity or any gluten-related problem, they're considered to be unsafe. So among all this, remember the most problematic, gluten is going to be the gliadin. So wheat is the most important problem, and the gliadins are the most important. And this is having the highest hypersensitivity risk compared to any other gluten which you have described. So in the gluten, there is a subdivision. I mean, there are two types are there. In the gluten, two components are there. One is glutenin and second is prolamin. In the prolamin, you have gluten prolamins and non-gluten prolamins. Non-gluten prolamins, maize, corn, rice, millets, and sorghum are completely safe. And gluten prolamins are dangerous. In that too, we have in oats, we have something called avenin, which is controversial. But the Triticea tribe, which is of wheat, rye, barley, which contains gliadin, secalin, and hordein respectively, are considered to be unsafe. In that, the most unsafe is considered to be the gliadins, which are found in the wheat. Clear? So typically, what are the things that the celiac disease patient should avoid? So we can remember by a mnemonic called BRO. So that's how I remember. BRO is something that has to be avoided in celiac disease. Or any patient with gluten hypersensitivity, you have to avoid BRO. So what about BRO? B stands for barley, rye, oats, wheat. In that, the most unsafe I told you is the wheat. Controversial is the oats. So, but in general, in any patient celiac disease or any patient gluten hypersensitivity, it could be non-celiac also. We generally ask the patient to avoid this BRO-related compounds. Barley, rye, oats, and wheat. In that, wheat is the most dangerous, which contains the gliadins. So, what are the dangerous prolamins? Gliadins, secalins, and hordeins. Avenins in oats are probably safe or not probably safe. So it is controversial, but definitely gliadins in wheat, which is the most dangerous, then secalin in rye and hordein in barley are completely unsafe. You should not take. Most unsafe is the gliadins only in wheat, which I told you multiple times. What are safe? Rice, corn, maize, millets, sorghum. So these are completely considered to be safe. All these are exam questions, so you need to definitely know about that. As far as pathophysiology is concerned, as I told you, there are multiple pathophysiological points are there. So we have a lot of diagram, but I don't know whether how much pathophysiology they will ask or not. I don't want to really discuss too much of pathophysiology for that matters. But in general, if you take wheat, so wheat is something that has gliadin. So gliadin does a lot of things. So this is going to increase modulate a type of signaling called zonulin signaling in the tight junctions on the enterocytes, because zonulin is the one that modulates the permeability of the tight junctions in the enterocyte. So once this gliadin alters the permeability of zonulin or alters the permeability of the enterocytes, then the tight junctions will resolve and this gliadin will start entering the gut. So it starts entry into the gut. So once the gliadin starts entering into the gut, it starts developing an inflammatory reaction. And we don't know really how it produces an inflammatory reaction, but it generally creates an inflammatory reaction. And to produce this inflammatory reaction, you need some background genetic factors like HLA, DQ2 and DQ8. And this inflammatory reaction is the one that results in production of increased intraepithelial lymphocytes and the production of certain antibodies, especially anti-TTG, IgA, and IgG. And IgA is more important, and they produce anti-endomysial antibodies, and they also produce this anti-gliadin antibodies. You have a big pathophysiology. You can tell pathophysiology alone for half an hour, but I don't think that is warranted. It's a very, very, low yielding exam point. So I don't want to discuss much. So gliadin is the problem. So gliadin will alter the zonulin signaling. Zonulin signaling will be modulated. And once the zonulin signal is modulated, they will gain entry into the intestinal lumen. Once they enter into the intestinal lumen, they're going to elicit an inflammatory reaction. To produce inflammatory reaction, your DQ2 and DQ8 are very important. Once you develop inflammatory reaction, you're going to have increased intraepithelial lymphocytes and you're going to produce antibodies. And this is going to result in ultimately damage to the mucosa. That's why celiac disease is a disease of mucosal damage. That's what is going to happen. So what are the risk factors for developing celiac disease? And the celiac disease pathophysiology is something that is going to have a very low yield. So we're not going to discuss much about this. It's a very, very low yield information. So no need to discuss more on the pathophysiology. The questions will be more clustered towards your diagnosis, and questions will be more clustered towards the manifestations and be more clustered towards the treatment of celiac disease. Pathophysiology wise, it's a very low yield information. Please don't waste much time on that. And what are the risk factors? Risk factors, number one is first degree relatives with celiac disease. Already, of course, this is an autoimmune disorder. And whenever you have a family history, they're going to have a high risk of developing the disease. And other autoimmune disorders like presence of type 1 diabetes mellitus, or Hashimoto's thyroiditis, or any form of autoimmune thyroiditis, or the patient is having autoimmune liver disease like autoimmune hepatitis, Sjogren's syndrome, or IgA nephropathy. So any other autoimmune disorders, the patient is having other disease association, and patients who are having Down syndrome, patients who are having Turner syndrome, and patients who are having IgA deficiency are known to develop celiac disease at a much higher rate compared to those without these risk factors. So risk factors are also very important. And what about the clinical features of celiac disease patients? Clinical features, as I told you, we can divide into intestinal features, and second one is extra-intestinal features. Extra-intestinal features. So what are the intestinal features? Of course, it's going to be chronic diarrhea, very common intestinal feature, and they will have weight loss. Other features of malabsorption, and they will have bloating and abdominal distension. And again, that's because of malabsorption, fermentation of substances in the intestine producing more hydrogen and carbon dioxide. And aphthous ulcers are quite common in patients with celiac disease as well. So you might think about Crohn's disease in exam, but remember, Crohn's disease, most common manifestation itself is aphthous ulcers. All these features, whatever I have shown you, can be seen in Crohn's disease patients also. So you cannot really differentiate based on symptoms. That's the most important point. But chronic diarrhea is usual common manifestation of celiac disease. Extra-intestinal is also very important. And if they ask you the most common extra-intestinal manifestation of celiac disease, answer is iron deficiency anemia. Very, very common. Multiple times asked question. In fact, there are quite a few patients who just present iron deficiency anemia without any of the intestinal features. They might be having intestinal features which will be mild, so the patient ignores generally, but they can frankly just present with iron deficiency anemia. So that is why if you take the British Society of Gastroenterology guidelines, in any patient with iron deficiency anemia, especially if it's a young patient, you need to do a celiac workup. So, I mean, in India, that sounds ridiculous because that will increase the cost unnecessarily. In India, it's very rare disease. But when you go to the Western countries like Britain, Northern Europe, Sweden, Finland, so there, one of the important workup in iron deficiency anemia itself is anti-DDGIG. You need to rule out celiac disease. It's just a common disease. They can present only with iron deficiency anemia without any intestinal manifestations. Also, that's why it's the most common extra-intestinal feature. And they might have increased liver enzymes. OTPT may be slightly increased, which is quite common. They might be having associated dermatitis herpetiformis, which I told you how they will present already. It's a blistering vesiculobular skin disease. And they might be having gluten ataxia. As I told you, these are associated problems, and they may be having hypocalcemia and low vitamin D. Very, very common. We have discussed this already. Duodenum is very important for absorbing iron and calcium. So patients who are having duodenal issues will be having iron deficiency anemia and hypocalcemia, because celiac disease is something that affects the duodenum more than any other part of the intestine. So most of the patients will be having iron deficiency anemia and hypocalcemia. And there are quite a few number of patients who tend to have hyposplenism. So we can write that in complications. So what are the complications you expect to develop in patients with celiac disease? The number one complication is going to be osteoporosis. That is due to malabsorption of fat-soluble vitamins A, D, E, K, and other fat-related compounds. So the patients will develop osteoporosis. Along with that, the patient will have hypocalcemia. That's also a risk factor for developing osteoporosis. And patients will develop hyposplenism. Many of the celiac disease patients will have hyposplenism that increase the risk of certain infections, especially with capsulated organisms. You know what are they? And patients can develop infertility, which is quite a complication of celiac disease, which can be associated with celiac disease. And patients can develop neuropsychiatric complications. Neuropsychiatric complications like ataxia. We talked about gluten ataxia, and they can develop seizures, and plus or minus because of the cerebral calcifications, you might get this ataxia and seizures, which is also a complication of celiac disease patients. Then they might have something called ulcerative jejunoileitis. This is quite rare with patients celiac disease. Usually they will present with strictures and perforation. Strictures and perforation. Remember, most of the times complications are common in patients who are not adherent to gluten-free diet. Patients who are not adherent to gluten-free diet, only those patients will usually develop complications. Other patients usually will not develop complications, especially with regards to this ulcerative jejunoileitis. This happens typically in patients who are not adherent to gluten-free diet. This happens in the long run. Suppose patients who are having celiac disease, you are telling gluten-free diet, but you're not adherent to gluten-free diet. And in exam, if you get a question where a patient who's a known case of celiac disease comes with stricture and perforation, and there is a history of non-adherence to gluten-free diet, this could be the possible diagnosis. That's called ulcerative jejunalitis, which comes with stricture and perforation. And celiac disease patients, of course, have increased risk of developing certain cancers. Like one is called as EATL, that's called enteropathy associated T cell lymphoma. Then we have something called jejunal adenocarcinoma. And you have some other GI cancers like oral cancer or oropharyngeal cancers, risk of developing oropharyngeal cancers. And I think if you remember the last session, I talked about esophageal cancer where celiac disease is a risk factor. So you can develop esophageal cancer if you have celiac disease, and patients can develop colon cancers, especially ascending colon. Right-sided colon cancers are common in patients with celiac disease. And finally, liver cancer. Liver cancer, whether there is an association or not, we don't know, but there are some studies which show association. That's why I'm telling. So these are the different cancers that have increased risk of occurring in patients with celiac disease. One is EATL, that is enteropathy associated T cell lymphoma. Second is jejunal adenocarcinoma. Third is oropharyngeal cancer. Fourth is esophageal cancer. Fifth one is colon cancer. And sixth one, finally, it is the primary liver cancer. So these are the 6 things that you need to know. And in general, usual things they will be asking you in exam, apart from intestinal problem, it's iron deficiency anemia, hypocalcemia, osteoporosis, hyposplenism, ulcerative jejunolitis, and enteropathy associated T cell lymphoma, and esophageal cancer, and oropharyngeal cancer. So these are the usual things they will be asking in exam. They will be targeting, and infertility may or may not be asked. We don't know. Ataxia, I don't know whether they will ask or not. So, but usually asked questions in exam are these things. So don't forget the hyposplenism part. Multiple times asked question. I don't know why examiners are very fond of hyposplenism, but they still do tend to ask this hyposplenism very commonly. So don't forget that. And how will you diagnose? How will you make a diagnosis? The most important is the antibodies. Antibodies are very important because without antibodies, you cannot make a diagnosis like this because it's an autoimmune disorder. Why hyposplenism? It's a association of celiac disease. Most of the patients with celiac disease will have hyposplenism. Probably when you go for the pathophysiology properly, they believe that most of the immunity is spent towards, like the gut. So that is why the immune system is exhausted, and that's why the splenic resources are exhausted. That's why they go for hyposplenism. That is what is thought to be the reason for hyposplenism, but we don't know the exact reason. But nevertheless, they believe that the gut being one of the biggest organs in the body, if you take the surface area of the gut, it's very, very high. So it's more than any other organ when you take the surface area of the gut. So what happens in celiac disease, you spend a lot of immunity or wasting it on the gut. So you're producing a lot of immune reaction in the gut. So probably you're spending a lot of immunity in the gut, and you're not having sufficient immunity to fight for other infections. That is the reason why they think that could be high risk of recurrent infections. And since the spleen spends a lot of immunity on the gut, so probably they expect celiac disease patients to have a hyposplenism. But this is the theory, but we have multiple other mechanisms as well, which is again beyond the scope of the discussion right now. Anyways, let us move on to the diagnostic standpoint, that is antibodies. As far as antibodies are concerned, there are multiple antibodies that we test for. One is the classic anti-TTG IgA antibodies, which are considered to be the most sensitive investigation as of now, and it's the first investigation that we do, and it's the screening test you do. Whatever you ask, answer is anti-TTG IgA. First investigation, screening investigation, and of course the best investigation. You cannot call it investigation of choice because only with antibodies alone I cannot diagnose celiac disease. But nevertheless, this is one of the best investigations, first investigation, screening investigation, most sensitive for all these things, anti-TTG IgA. So what is the sensitivity? Sensitivity is typically more than 95%, and specificity is also more than 95%, which means it's an excellent investigation overall for celiac disease, anti-TTG IgA. Second one, you have something called anti-endomysial antibodies. IgA, anti-endomysial antibodies. So this is considered to be most specific just on paper, because if we talk about the sensitivity is more than 90%, and specificity is more than 99%, which means compared to anti-TTG IgA, if you ask the most specific on paper will be anti-endomysial antibodies only, but really don't do this investigation in reality. But we generally stick on to anti-DGIG. That's the usual investigation that's done. Anti-endomysial in practice we don't do, but on paper, if you ask, this is the most specific antibody just for the theoretical scenario. And there are some other investigations that are not used, like for example, HLA DQ2 and DQ8. This is very, very sensitive. The sensitivity ranges from 91 to 100%. Very sensitive investigation, but specificity is very, very poor, less than 50%. In the sense, like not all patients not all patients with HLA DQ8, DQ2 will have celiac disease, but almost all will have. All celiac disease patients will have DQ2, DQ8 positive. That's why it's very sensitive, but it's not specific, but it's generally not done to diagnose celiac disease. And next is IgG anti-gliadin antibodies. Anti-gliadin antibodies. Again, these are not used because their specificity and sensitivity is also very less. Anti-gliadin antibodies are not generally performed. So usually, if you want to perform one investigation, that is anti-DIGA plus or minus anti-endomysial IgA, which is not done usually in practice, but actually DQ8 and DQ2 and anti-gliadin antibodies have literally no role because the specificity and sensitivity are quite low. So among the serology, the one best test is anti-DDG IgA, which is both highly sensitive as well as specific, but on paper, the most specific will be anti-endomysial IgA. Along with that, second evidence should be that there should be enteropathy should be there. Just with antibodies alone, you cannot diagnose celiac disease. There should be enteropathy evidence. Enteropathy evidence can be got from endoscopy and biopsy, which shows the enteropathy. Remember, this enteropathy is non-specific. I'm talking about, like with the endoscopy alone, you cannot make a diagnosis of celiac disease. It is a non-specific enteropathy. What will you really see? I told you multiple times in the past, like just 10-20 minutes before we discussed on enteropathy, you will see villus atrophy, crypt hyperplasia, and increased intraepithelial lymphocytes. And in a gross view endoscopy, you will be seeing that scalloping of the mucosal folds. This is very, very classic feature of celiac enteropathy. But remember, celiac enteropathy is non-specific. Why celiac enteropathy is non-specific? Because you can see the same finding in multiple other conditions. Like I told you in tropical sprue, you can see a similar finding. You can see in SIBO, you can see in viral gastroenteritis. In many other conditions, you can see the same finding. So it's non-specific as far as celiac disease diagnosis is concerned, but definitely enteropathy as a whole should be there in patients with celiac disease. Without that, you cannot make a diagnosis. And you can do test for malabsorption. Third thing is you can do test for malabsorption. When you do test for malabsorption, the most important is the abnormal D-xylose test. That is the most important clue in exam. Apart from that, they'll be having an abnormal Schilling test also. They might be having increased fecal fat, but they'll be having a normal fecal elastase. So clearly increased fecal fat with normal fecal elastase will tell you that the pancreatic function is normal pancreatic function. Abnormal D-xylose test will tell you there is a damaged mucosa, which means the mucosal integrity is abnormal. That's what it means. That's what abnormal D-xylose test is. So this is the classic test that you will, the pattern that you will get in exam with regards to celiac disease. But this is not generally required. Whenever you suspect the celiac disease, you're going to make a diagnosis based on antibody, especially anti-DGIG. And second thing is endoscopy to prove the patient is having enteropathy. So if you have these two symptoms, antibodies, evidence of enteropathy in endoscopy, that's enough. This is enough to make a diagnosis of celiac disease. So which means there's no standard test of choice or investigation of choice. It's like a complementary testing. You need to have these evidences to tell that the patient is having celiac disease to make a correct diagnosis. That's why whenever some student asks me the investigation of choice in celiac disease, I get confused because just with anti-TGIGA, you cannot tell celiac disease. Just with an endoscopy alone, you cannot make a diagnosis. Just with symptoms alone, you cannot make a diagnosis. It's like a combination of your clinical features, your serology, as well as your endoscopy. All these three things should be there to make a diagnosis of celiac disease. Clear? So then, as far as histology is concerned, when you do a biopsy, we did a biopsy, isn't it? I told you what is the biopsy finding that you will see. One is the villus atrophy. Second one is the crypt hyperplasia. And third is increased intraepithelial lymphocytes. So based on this, there are two classification systems. Histological classification systems are there. One is called as Marsh classification system, and second is the Corazza classification system. In that, what they will be asking you in exam is the Marsh. This is what is given in Robbins pathology text. That's why they will ask you about Marsh. So as far as you have three types of Marsh. One is called as type 1 Marsh, type 2 Marsh, and type 3 Marsh. As far as type 1 Marsh is, on all these three types, you will have increased intraepithelial lymphocytes. Increased IELs is a feature of all these three. And if you see crypt hyperplasia additionally, it is type 2. Crypt hyperplasia may be seen in type 2 and type 3. And if you see villus atrophy, that is definitely type 3. So which means in type 1, you will see only increase intraepithelial lymphocytes. In type 2, you will see intraepithelial lymphocytes along with crypt hyperplasia. In type 3, you will see increased intraepithelial lymphocytes with crypt hyperplasia and villus atrophy, which is not a feature of type 1 and type 2. So as far as villus atrophy, I told you villus atrophy will be seen only in type 3. As far as villus atrophy is concerned, you have three types. One is called as partial villus atrophy. That's called 3A. And 3B, you have a subtotal villus atrophy. And then finally, we have a 3C, that is called as a total villus atrophy. So this is Marsh classification. 1, 2, 3. All these three types, you will have increased depth of lymphocytes. Crypt hyperplasia only in type 2 and type 3. Villus atrophy only in type 3. And if you have a partial, that's type 3A. If you have a subtotal villus atrophy, it's type 3B. And if you have a total villus atrophy, it is type 3C. So this is Marsh classification. And you have another classification, only the name is important. It's called a Corazza classification system. And as far as treatment is concerned, the most important, the best treatment and the cost-effective treatment is gluten-free diet. And it should be lifelong, sustained gluten-free diet. Typically, I told you, gluten-free diet is very, very important. And what are things that you need to avoid? One is bro. Avoid bro, as I already told you. And second is avoid certain liquor called slab. So what are the liquor that you have to avoid, which contains gluten? One is stout. Second is lager. Third is ala. And fourth is beer. So all these things will contain a little bit of gluten. So you need to avoid bro, that is barley, rye, oats, and wheat. And slab has to be avoided. That is stout, lager, ala, and beer. So these are the things you have to avoid. So this is the treatment, then this is the only treatment, and this is the best treatment. So whatever you ask, this is the only treatment. You don't have immunosuppressants, you don't have steroids, you don't have any treatment. So, and it should be lifelong. And this is the only treatment for celiac disease patients. There's no other treatment. So if they adhere to this, they do well. If they don't adhere to gluten-free diet, they do bad. They develop complications over a period of time. So how will you monitor the patients with gluten-free diet? So remember, there are two things where you are going to monitor. One is anti-TTG IgA. Remember, anti-TTG IgA is not only used for diagnostic purpose, it's for prognostic purpose also. With strict adherence to gluten-free diet, it generally disappears over a period of time. They'll become negative. So this is one way you can monitor the patient is adhering to gluten-free diet or not. And second is the clinical improvement. Clinical improvement will be there, which happens within a period of 2 weeks. In approximately 2 weeks of gluten-free diet, the patient will get a clinical improvement. And third is histological improvement. In endoscopy, there will be a improvement, histological improvement. To get a complete histological reversal, that is normal histology, it will take around approximately 6 to 24 months. Up to 2 years it can take, but still they will develop a complete histological improvement over a period of time, and the symptoms will completely disappear, and the antibodies also completely disappear. Which means that three cornerstone of diagnosis of celiac disease: the intestinal symptoms, second is the antibodies, and third is the histological features, biopsy, endoscopy. All these three things will completely get better once the patient adheres to gluten-free diet, which means you can tell that the celiac disease will disappear if the patient is on gluten-free diet. So all the characteristic features of celiac disease we studied will disappear with gluten-free diet. The patient continues to have gluten-free diet, The patient will have continuing symptoms. The symptoms will not resolve. The patient will have persistent anti-TTG IgA. It will not disappear. And the patients will have persistent histological abnormalities. And endoscopy will show all the problems. It will not disappear. So, and at the same time, the patient is not adherent to gluten-free diet. They're prone for developing complications in the future, like ulcerative degenerative and multiple cancers also. So that's why the most cost-effective, best, easiest treatment is avoid gluten, and don't take gluten. That's all. And whenever the symptoms improve with gluten-free diet is equal to celiac disease. That's right statement or wrong statement. And people who are listening can tell whenever the patient is responding to gluten-free diet, is it a right? I mean, it's a celiac disease. It's a right statement or wrong statement? Wrong statement. Correct. So adherence to, when the patient is taking gluten-free diet, if the symptoms improve, it doesn't mean it's a celiac disease. I told you clearly. So resolution of symptoms with gluten-free diet cannot be used as a diagnostic point to diagnose celiac disease, because it's a common thing about the beginners. Whenever they are overconfident about diagnosing celiac disease, they will ask the patient to take a gluten-free diet. Once they go for gluten-free diet, the symptoms will resolve in many conditions, not only in celiac disease. It can resolve in non-celiac gluten hypersensitivity. It can resolve in wheat allergy. It can resolve in many other intestinal conditions, because wheat is a very common compound that creates a lot of intestinal symptoms. Not only in these patients who have diseases, even in patients who are normal, physiologically sometimes wheat can cause some reaction. So the gliadin is little dangerous. Gliadin is something that is not very good for intestine. So really speaking, so that is the reason why intestinal problems are very common in patients who are in northern India, where they take a lot of gluten, compared to southern India, where they take a little bit of less gluten. So gluten itself is not that good for intestine. Evolutionarily speaking, gluten is not something that we are supposed to consume, if you go back to the evolution and see. But still, we consume because it's, like we feel it's tasty, and it becomes a staple food for many people in northern India. So that's why, and there is a separate, like studies which tell like people who take gluten are prone for more risk of certain disorders, including cancers. But that's not completely proved, but nevertheless. So improvement with gluten-free diet is not a sign of celiac disease. It's wrong. So many conditions can improve. Many intestinal problems, even simple viral gastroenteritis can improve, because even in viral gastroenteritis, the mucosa will be very, like raw, and it will be damaged. So that time, if you take gluten, it will contain gliadin. Especially if you take wheat, it will contain gliadin, and this gliadin can already upgraded mucosa. It will cause more damage, because gluten is known to create inflammation, especially the gliadin in the wheat. So even in viral gastroenteritis might improve with gluten-free diet. So you can't predict that it's a celiac disease. Many benign and non-benign conditions can improve with gluten-free diet. So don't take that as a very important point. So let us move on to the next problem, that is tropical sprue. So we have discussed about celiac disease. So a quick recap of celiac disease. What are things we have discussed on celiac disease? One is the epidemiology we discussed, genetics we discussed, then the pathophysiology in nutshell we have discussed, then what are the different types of gluten-related disorders we described, and all gluten-related disorders are not celiac disease. Celiac disease means there should be autoimmunity and enteropathy. But symptom-wise, you cannot differentiate, because all these three things may have almost similar gastrointestinal symptoms. And what are the dangerous glutens? We discussed in that prolamins. What are the gluten prolamins that are dangerous, especially the TTCA group, that gliadins, secalins, and hordins are dangerous, then that contained in bro. And we discussed on the risk factors, we discussed on clinical features, intestinal, extraintestinal manifestations, complications of celiac disease, cancers associated with celiac disease, then serological diagnosis, endoscopic diagnosis, Marsh classification, Corazza classification. What are the different malabsorption test pattern in celiac disease patients? And gluten-free diet is the only treatment that you need to know. All the known diagnostic points for celiac disease that you have discussed will disappear with gluten-free diet over a period of time. That's all. So then there are quite a few other disorders in malabsorption which are not that important, but still you might be getting an exam, is the tropical sprue. Tropical sprue is something that is important. So the name why they call this tropical sprue is because it mimicked the celiac sprue, but it is different from celiac sprue in the fact that they do not have antibodies, number one, and still they had enteropathy, number two, and there is no gluten hypersensitivity, which means patients taking gluten do really well. And gluten is not known to exacerbate the disease, or gluten-free diet is not shown to show sufficient improvement. Remember, even tropicals prove I mean, if you take theoretically speaking, if you take the textbooks, literature, even tropicals prove will sometimes respond to gluten-free diet to some extent. But that's, like that's like a confusing thing, and that's completely ridiculous. Telling gluten-free diet improving the symptoms is celiac. That's totally wrong. Any disease can respond to gluten-free diet. That we are not talking about that. But ideally speaking, there will be no gluten hypersensitivity in patients with tropical sprue. And it happens in the tropics, especially in countries like Indian subcontinent. That's why it's called as tropical sprue. In the sense, probably it might be due to some infection. We don't know. Many candidates are there, like E. coli, Klebsiella, Enterobacter. Many, infections has been postulated, but we don't know what infection exactly. But it happens in the tropics, and it's believed that it is due to some infection in the gut. But what are the differences? One is the distal intestine is affected more than the proximal intestine, which means it can still develop iron deficiency anemia and hypocalcemia. I'm not telling that it will not develop iron deficiency anemia and hypocalcemia. Still, you can develop iron deficiency anemia and hypocalcemia. But because distal intestine is involved, they'll typically produce more B12 deficiency compared to that of celiac disease. Celiac disease, B12 deficiency is not that common. But remember, if you ask, it can happen. It's not like it cannot happen. It can happen in celiac disease also, but it's late and it's not a very common feature. But in tropical sprue, one of the striking features is B12 deficiency. It happens very early. The distal intestinal involvement, especially the distal ileal involvement, is one of the very striking and early features of tropical sprue, which is uncommon in celiac disease. But remember, iron deficiency anemia, hypocalcemia, and B12 deficiency can happen in both celiac as well as tropical sprue. But B12 deficiency is very striking and early in tropical sprue, but iron deficiency anemia and hypocalcemia is more and striking and early in celiac disease patients. But apart from that, all other features of malabsorption will be there in both chronic diarrhea, weight loss, anemia, steatorrhea, bloating, cramps, fatigue. All these things will be there in patients with celiac disease as well as tropical sprue. Diagnosis wise, it's very challenging because it's very difficult to diagnose, because if you do a endoscopy and biopsy, you will see the same finding which I've told you. You will see villus atrophy, you will see crypt hyperplasia, scalloping of the intestinal folds in gross view of endoscopy. You will see that increased intraepithelial lymphocytes. Everything can be seen in tropical sprue patients also, so that doesn't tell you anything. At the same time, the abnormalities will be quite typical. So D-xylose test will be abnormal, and patients will have abnormal Schilling test. This is for sure. They will have abnormal Schilling test, and the patients will have increased fecal fat. They might have, and they might have a normal fecal elastase. So which means, again, you cannot really differentiate from celiac disease based on this test. So which means these tests are only supplementary tests. Very challenging diagnosis. Only thing that tells you it's not celiac disease is the fact that there are no antibodies here. So because there are no antibodies, you're not able to tell it's a celiac disease. That's all. Apart from that, many other features may be overlapping with that of celiac disease. But it's believed that it's due to infections. Why we believe it's due to infections? Because when you treat this disease with antibiotics, it generally improves. Like for example, we give doxycycline for a period of 3 to 6 months. Usually we give it a dose of 100 milligram 2 times a day, 100 milligram BD for 3 to 6 months, along with folate supplementation, folate and B12 supplementation. Generally, the disease improves over a period of time if we give antibiotics for a longer period of time. So because it responds to antibiotics, we believe it's due to probable infection. The chronic resistant invasive infection into the gut is probably thought to be the reason for developing tropical sprue. But nevertheless, the most important thing in exam you need to think about when you want to make a diagnosis of tropical sprue is the negativity of antibodies. That's very important and key. And B12 deficiency will be striking and early, and the patient will not have any gluten hypersensitivity. This is the key point in exam. All the other things may be similar to that of celiac disease. Treatment is with antibiotics. And then when it comes to Whipple's disease, Whipple's disease is such a common question in exam. Very important thing to note in exam, especially when it comes to GIT. So you know what is the organism that is called Trophyma whipplei. It's very difficult to culture because it's an intracellular organism. Whenever the organism is intracellular, it's very difficult to culture, and it's supposed to be a gram-positive bacillus, gram-positive organism. And of course, they will be PAS-positive diastase resistant, PAS-positive organisms. That's very, very important. So these are the classic features of the organism that you're talking about, that is Strophyma vipili. And routes of transmission. This is something that we don't know. It's a medical enigma. We don't know what is the routes of transmission. If you tell fecal-oral route, it's wrong. We really don't know how it's getting transmitted to the humans. It's a very rare disease. It's not a common disease in the first place. Very rare disease. If it's going to be fecal-oral transmission, it should be common in the community. It is not common in the community. It's very rare. And it's not like it's going to affect immunocompromised individuals. It affects immunocompetent individuals also. So we don't know the pathophysiology. We don't know the routes of transmission. We don't know what are the reservoirs in the community. So it's something that is an enigmatic disease. But we know the organism. But at the same time, we don't know the transmission route, and we don't know what is the exact, like reservoir and all this stuff. And this is a disease that affects proximal and distal intestine in equal proportion. So celiac more proximal, tropical sprue more distal. But this is some disease that affects both proximal and distal intestine almost equal proportions. As far as the clinical features are concerned, you have once again intestinal features and extraintestinal features of Whipple's disease. Intestinal features, typical malabsorption syndrome. That's how they come. Typical malabsorption syndromes, which chronic diarrhea, abdominal pain, bloating, weight loss, fatigue. So typical, but more important is the extraintestinal features. In exam, they will be concentrating on the extraintestinal features. There are multiple extraintestinal features will be there. And if they ask you the most common extraintestinal feature, that is arthralgia and arthritis, which will be seen in almost 2/3 of the patients. Like 70 to 80% of the patients will have some extraintestinal arthritis and arthralgia. So that's the most common extraintestinal feature. They might have sacroiliitis. Sometimes you might think whenever they give the sacroiliitis, sometimes you might get confused in reality. You might be thinking about an IBD because ulcerative colitis IBD is also associated with seronegative spondyloarthropathy. So you might think about that also, but still it is seen in almost half of the patients. Sacroiliitis, back pain will be there. And fever is very, very common. Then serositis, especially polyserositis, due to peritoneal and pericardial pleural involvement. That is abdominal pain, chest pain is very common. Patients may have lymphadenopathy, especially mediastinal lymphadenopathy, and they can have peripheral lymphadenopathy also. Very difficult diagnosis to pick up. It's not at all easy diagnosis to pick up. Then they can have cardiac involvement. Cardiac involvement, they can produce infective endocarditis. They can produce myocarditis. They can produce pericarditis also. But in general, endocarditis is very important and it will be asked in exam. Then neurological involvement in Whipple's disease. And if they ask you most common neurological involvement, answer will be dementia. Dementia, very, very common. And apart from that, they can produce myoclonus. They can produce nystagmus. They can produce supranuclear ophthalmoplegia. They can produce ataxia. So many problems. But the most common will be dementia. That's a very common question in exam. And they can develop hepatosplenomegaly. They can produce skin involvement, which produce hyperpigmentation. They can produce uveitis, rare but still can happen. So many like extraintestinal manifestations are there. But in exam, usually you will get malabsorption, you will get arthritis in a patient who is having dementia and endocarditis, plus or minus. So this is the key in exam. So if you have features of malabsorption, arthritis, and dementia, plus or minus endocarditis, you're dealing with a case of Whipple's disease. That's all. So this is how you make a diagnosis in exam. So without extraintestinal manifestation in exam, you cannot make a diagnosis of Whipple's disease. Or they will give a straightforward clue. Investigation-wise, there are many serological and other investigations, but in exam, they'll give only one, that typical PAS positive AFB negative macrophages in the intestine. So if they give this in endoscopy and biopsy, that is equal to Whipple's disease. That's the only thing that you can diagnose only with malabsorption. If you have only intestinal symptoms, you need to have this. Without that, you cannot diagnose Whipple's disease. Or if you want to diagnose clinically in exam, without endoscopy and biopsy, you need to have intestinal and external manifestation, which will have neurological and cardiac involvement and arthritis. If you have malabsorption with dementia and arthritis, then you can go for Whipple's disease. Otherwise, you need to have this evidence of PAS positive macrophages in the intestinal epithelium. Treatment wise, very difficult. Very difficult to treat. Eradication is quite difficult. There are multiple regimens are there, but in general, we can give 2 weeks of IV ceftriaxone, 2 grams once a day dose. We give 2 weeks of IV ceftriaxone. Then this should be followed by maintenance dose of trimethoprim and sulfamethoxazole for 1 year. So which means it's a long-term treatment. It's a long-term commitment. Even after 1 year of treatment, you are not very sure that the disease will completely resolve. You might not have like complete resolution of this disease. So that's something which has to be noted. And the relapse rates are very high. So it's very difficult disease to treat. And this is one disease which is invariably fatal if you don't treat, which means it's a 100% lethal disease. If you don't treat, the patient will surely die. There's no doubt about that. Because of multiple extraintestinal complications and manifestations, they will die. But nevertheless, so treatment is long-term. 2 weeks of IV ceftriaxone, then followed by 1 year of cotrimoxazole. That is what you're going to use for treatment. As far as A beta lipoproteinemia is concerned, we have discussed already in the past about A beta lipoproteinemia. Whenever you have a patient who's having malabsorption with acanthocytes in the peripheral smear and this lipid-laden macrophages in endoscopy and biopsy, that is A beta lipoproteinemia. Apart from that, multiple other things are there. For example, clues will be the patients will be having deficiency of fat-soluble vitamins, because whenever you have A beta lipoproteinemia, they cannot produce chylomicrons. When they cannot produce chylomicrons, they can absorb fat. It's not a problem, but it cannot be produced to chylomicrons to put into the lymph and put into the chyle. So that's why they are having this lipid-laden macrophage. So the fat malabsorption will be very severe. In the sense they might have severe steatorrhea, failure to thrive, and they'll have deficiency of all fat-soluble vitamins. And this is a disease that presents very early in the life because it's a genetic disorder. And if they ask you the mutation that happens in A beta lipoproteinemia, answer is MTTP. I think this is something we have discussed in the premium lectures in endocrine. When I'm talking about lipids, I told you there is something called microsomal triglyceride transport protein, or MTP, microsomal transport protein, or microsomal triglyceride transport protein is there. If MTP is defective, you get a disorder called A beta lipoproteinemia. We discussed there itself. So it's not only about chylomicrons. You cannot produce VLDL, you cannot produce LDL, you cannot produce any lipoprotein particle for that matters. So there'll be extremely low level of cholesterol. So what are the clues for A beta lipoproteinemia? Let me write, because this is something that might be asked in exam. A beta lipoproteinemia. Number one, I told you the problem is in MTTP, microsomal transport protein. So one is malabsorption that presents early in life. And second is your acanthocytes in the peripheral smear. Definitely this is a clue. And third is very low total cholesterol. LDL, chylomicrons and all will be undetectable most of the times. Very low total cholesterol. In fact, most of the patients will have completely absent LDL. There will be no LDL in the blood. And of course, biopsy will show this lipid-laden enterocytes. Lipid-laden enterocytes. This is the biopsy finding. And complication-wise, because of the loss of fat-soluble vitamins, they will develop osteoporosis. They will develop other problems like ataxia, spinal cord involvement because of vitamin E. Whenever vitamin deficiency is there, they will have spinal cord involvement like ataxia, then corticospinal tract involvement. All these things will happen over a period of time. So that's why the treatment will be, you have to restrict long chain fatty acids, which are very difficult to absorb. At the same time, you need to give very high dose of vitamin E, because the vitamin E malabsorption itself will result in many neurological complications. So this is how you treat A beta lipoproteinemia, but nevertheless, this is a very important topic for exam, which they will be asking. So then moving on to some few final stuff which you need to discuss. One is the small intestinal bacterial overgrowth. So as the name suggests, this is a small intestinal bacterial overgrowth, which means there is more bacteria in the intestine than it is supposed to be. So there are multiple etiologies are there. As far as etiologies is concerned, so one, it could be motility disorders or structural abnormalities. Or second, it could be motility disorders. Third, it could be some functional disorders. So what are the structural disorders? As far as structural disorders are concerned, diverticular. So diverticular outpoaching of the intestinal mucosa, right? diverticular. So this diverticular, because of the outpouching, in that pouch, there might be a local bacterial overgrowth might be there. So this can typically result in a small lesional bacterial overgrowth. So diverticular are very, very important. Then next is strictures. Strictures will prevent the movement of the food particles down and movement of the bacteria also further. So there will be a local overgrowth of the bacteria. So the reason for stricture can be anything. It could be some ischemic disease. It could be due to radiation, which can cause strictures. It could be due to Crohn's disease, which can cause strictures. TB can cause strictures. So many conditions can cause strictures. So strictures, anything that causes strictures, and adhesions, very common after surgeries. Usually they cause partial obstruction. That's why the movement of the fecal matter is reduced. So that's the reason why it happens. And in patients who are having post-gastrectomy, especially after Billroth 2, anastomosis, they are likely to have afferent loop stasis. You would have studied something called afferent loop syndrome and afferent loop syndrome in surgery after this Billroth gastrectomies. It's a very common question in your final year exams. But nevertheless, there will be afferent loop stasis. So because of that, there might be local bacterial overgrowth. And fistulas, the GIT can also result in development of small intestinal bacterial overgrowth. It could be gastrocolic fistula, or it could be jejunocolic fistula, or it could be jejunolileal fistula. So any intra-intestinal fistulas can result in development of this bacterial overgrowth. And motility disorders wise, the most important is going to be scleroderma, very, very important. And apart from that, as I told you, low motility will be seen in amyloidosis, after vagotomy, diabetes, that is because of autonomic neuropathy. Diabetes will, what is autonomic neuropathy? They will damage the vagus nerve endings. So because of that, there will be low motility. So that's the reason. Motility means they're talking about low motility. So diabetes due to autonomic neuropathy. And there is something called intestinal pseudo obstructions there. The multiple headings under this, which are not going to discuss right now. But scleroderma, diabetes, vagotomy, amyloidosis are very, very important. These are the conditions that produce low motility. Because of that, they produce SIBO, small intestinal bacterial overgrowth. And some functional disorders are there, like, for example, hypochlorhydria or achloridria. That happens due to atrophic gastritis. Because you know that acid in the stomach does a very good job in killing the bacteria. Suppose if there is a very limited acid in the intestine, your killing job will be imperfect and it will not be that good. So that's why there might be risk of developing bacterial overgrowth. And if there are low immunoglobulins, like for example, if you have a hypogamma globulinemia, or if you have a gamma globulinemia, so your gut immunity will be poor. So because of that, there might be bacterial overgrowth. So these are the conditions that produce bacterial overgrowth. But no matter what, so there will be something that produces bacterial overgrowth. There will be some predisposing factor will be there. So what are the pathophysiology? So why bacterial overgrowth should produce issue? So whenever you have a small intestinal bacterial overgrowth, so it produces a variety of complications. One is it uses B12, increased B12 utilization by the bacteria. And this will result in B12 deficiency, resulting in a megaloblastic anemia. Second thing, this is one of the striking features of SIBO. And second is, because of more bacteria, they cause fermentation of carbohydrates. And this will result in more H2 and more carbon dioxide production. And that will result in development of bloating, abdominal pain, and severe symptoms will be there. Bloating, flatus, recurrent flatus will be there. This gas will be passed. So flatus, abdominal pain, very common. Plus, at the same time, more bacteria will deconjugate the bile acids. So like for conjugation, deconjugation of bile acid, bacteria important. If there is more bacteria, they're going to deconjugate the bile acids more. So if they deconjugate the bile acids more and more, there will be reduced fat emulsification. So one of the important function of the bile acids is to produce something called as fat emulsification. Whenever you don't have sufficient fat emulsification, because there are low bile acids, you will result in steatorrhea. And that is diarrhea, nothing else. So the patients will end up with chronic diarrhea, weight loss, steatorrhea, bloating, abdominal pain, increased flatulence, B12 deficiency. This is very typical of a SIBO. But even though none of these features can be specific for SIBO, but these are the usual features that happens in patients with SIBO. And how will you diagnose? Diagnosis is very, very important. Usually, clinically, there will be some risk factor for development of SIBO will be there. Like I told you, some structural problem or motility problem or functional problem will be there. Along with that, the patient comes with these symptoms. If you're having a strong suspicion of SIBO, then you can do something called a breath hydrogen test. This is the number one test. This is the usual non-invasive test that we do, breath hydrogen test. Or you can do breath methane test also. Breath methane test also. So after giving lactose, so you have to measure post-lactulose. After giving lactose, suppose if there is more bacteria in the intestine, there will be more hydrogen and methane production. So more hydrogen in the sense if it's more than 20 parts per million, I told you already. In the breath, that is suggestive of a SIBO. That's abnormal value. And breath methane, if it's going to be more than 10 parts per million. So this is at 90 minutes, within 90 minutes. And this is no time, regardless of time. Whenever, regardless of time, if your breath methane is more than 10, that is suggestive of SIBO. This is considered to be more specific. I mean, because breath hydrogen can be increased even in patients who are having what is that, lactose intolerance or lactase deficiency or disaccharide deficiency. But methane is more specific for patients with SIBO. So more breath hydrogen, that is more than 20 parts per million within 90 minutes after giving lactose, or more breath methane regardless of the time if it is more than 10 parts per million after giving lactose, that is suggestive of SIBO. This is one type of non-invasive test. But if they ask you the gold standard is the aspirate of the culture. So you are going to do something called a jejunal aspirate. This is a very common question in exam. If at all you need to diagnose SIBO, if they ask you absolute gold standard, answer is jejunal aspirate. So you need to take the jejunal aspirate. It's very difficult to collect jejunal aspirates during endoscopy. You have special tubes and all for that. But nevertheless, suppose in the jejunal aspirate, if it's more than 10 power 3 organisms per ml of the aspirate, 10 power, that is 1000 organisms per ml of the aspirate, that is suggestive of a SIBO. Suppose if it is more than 10 power 5 organisms per ml, that is used for diagnosis of iatrogenic SIBO, like it's due to some adhesions, bowel adhesions after surgery, after vagotomy, afferent loop syndrome. After surgery, if you're going to result in SIBO, if it's more than 10 power 5 organisms per ml, that indicates iatrogenic SIBO. But in general, if the jejunal aspirates are showing more than 10 power 3 organisms per ml, that is called as, that is the diagnostic standpoint of SIBO, and that is supposed to be the gold standard for diagnosis of SIBO, jejunal aspirate. So this could be a question in exam. So what is the gold standard for diagnosing of SIBO? Answer is jejunal aspirate. Alternatives are breath hydrogen and breath methane after giving lactose. So treatment, you have to treat the correctable, problems. For example, correctable lesions. So what are the correctable lesions? Most of the structural problems are correctable. So for correctable lesions, you can do the correction. For example, for fistulas, strictures, adhesions, diverticulum, you can do surgery if you want. So these are correctable problems. But there are some things which are non-correctable. So these are considered to be non-correctable causes. In the sense like scleroderma is something that is non-correctable, diabetic autoimmune neuropathy is something that is less correctable, amyloidosis, vagotomy, pseudo-obstruction, very difficult to correct. So when you encounter non-correctable cause, you have to give antibiotics. Antibiotics typically. Antibiotics in the sense like very common drug that we prefer is giving a amoxiclav. Augmentin, amoxicillin clavulanic acid plus or minus metronidazole. Alternative drug that we can try is rifaximin. These are two drugs that we use, either a combination of amoxicillin clavulanic acid and metronidazole, or alternatively you can use rifaximin. So these are the usual drugs that we use to treat small intestinal bacterial overgrowth if it's due to a non-correctable cause or a poorly correctable cause. Clear? So this is SABO. So how will you diagnose SABO in exam? Whenever the patient is having abdominal and malabsorptive symptoms with a predisposing cause like recent surgery, stricture formation, and patients having a typical B12 deficiency, think about a SIBO. The test in that situation will be gold standard means jejunal aspirate. Otherwise, alternatively, you can use a breath hydrogen or breath methane after a lactose, a dose of oral lactose. Treatment will be with antibiotics. Rifaximin is one of the attractive options, alternative to amoxicillin and metronidazole combination. So then we have something called as short bowel syndrome. I think perhaps this is the last of the day. We are going to discuss on something called short bowel syndrome. So what do you mean by short bowel syndrome? As the name suggests, here the patients are having problems due to massive resection of the intestine. due to some surgical reason. So you have resected too much of intestine. Because of that, you are ending up with a short bowel, and because of that, your intestinal function is deranged and affected, and you are resulting in a development of short bowel. So small segment of the bowel that is causing a lot of problem. So there are some reasons why you get a short bowel in adults and children. Remember, surgical resection is the usual reason. In adults, Crohn's disease, because it causes multiple strictures. You need to resect these areas that have severe strictures. And in fact, this is supposed to be the most common reason in adults to have a short bowel syndrome. And it could be a massive intestinal trauma, or it could be a mesenteric ischemia. These are rare causes. These are not very common causes at all. Mesenteric ischemia and malignancy, rare. Malignancy usually you resect only a short segment of the bowel, or radiation enteritis. Radiation will cause strictures throughout the intestine sometimes. So you need to resect a large segment of the intestine. So that might result in problem. So, but usually in adults, the most common reason for ending up in a short bowel syndrome due to repeated surgeries is Crohn's disease. In children, the most common cause is necrotizing enterocolitis. Very, very common in children. Usually necrotizing enterocolitis is common in preterm infants. Because of that, you might be needing to resect a wide, length of the bowel, so that, a significant length of the bowel will be resected, so resulting in short bowel syndrome. Or some congenital abnormalities. Congenital anomalies, the most important, I believe, is the midgut volvulus. You have studied in surgery, right, about midgut volvulus. In pediatrics also they will discuss. There is something called a whirl sign in CT scans that is suggestive of a midgut volvulus in children. And midgut volvulus is something that is discussed in anatomy, that is embryology part. It is discussed in pediatrics, it's discussed in surgery, it's something that's discussed in everywhere. And you would have studied about that single bubble, double bubble, triple bubble sign, where you see all those things. You see that in duodenal atresia, jejunal atresia, where you see triple bubble, duodenal atresia, double bubble. So you see a lot of things, isn't it? So many congenital anomalies, and gastroschisis is there. So many congenital anomalies you might be in a situation where you need to resect a lot of segment of the bowel. That might result in the development of short bowel syndrome. But nevertheless, so we need to know some data. What is the normal bowel length? Normal length of the bowel, especially small intestine. Remember, colon, if you remove, it will not result in malabsorption. But small intestine, if you remove, definitely result in malabsorption. Normal length of small bowel. We're talking about normal length. Adults, it's different. In children, it's different. In adults, it's approximately 250 to 800 centimeter. This is the normal length of small bowel in adults, like 2.5 meters to 8 meters almost. But in children and infants, not about children, maybe talk about infants, because necrotizing enterocolitis is very common in this preterm infants only. So in infants, especially who are at term, newborns at term, they'll be around 1.5 to 1.6 meters, which means 150 to 160 centimeters. This will be the length of the bowel. So when you get short bowel syndrome, so for that you need to have a significant resection of the bowel. So typically happens in adults if the bowel length after resection, the residual bowel length is less than 160 to 180 to 200 centimeter. Less than 180 to 200 centimeter. Which means we are resected so much that the residual bowel length is less than 180 to 200 centimeter. Or in infants, if it is less than 75 centimeter, half, less than 75 centimeter in infants. Or if you are resected, whether it could be adults or infants, if more than 70 to 80% of the bowel is resected, of small bowel resected. So there are multiple definitions are there, but it's more of a understanding scenario. It's not like it's based on definition. This is only for, just to give a number, I'm telling you this, but it's something more of an understanding thing. Visibly, if you resect a lot of bowel, the patient is going to end up in complications. So, but normal length, just numbers wise, normal length, adults 250 to 800 centimeter. In children, it is 150. Especially at term, infants will be 150 to 160 centimeter. If the resected length is more than 70 to 80 centimeter, 80% of the entire bowel length, or if the residual bowel length is less than 150 to 180 to 200 centimeter in adults, or less than 75 centimeter in infants, there is a lot of chance that the patient might go for short bowel syndrome. So that is what is going to happen. So There are basically three types of short bowel syndrome based on anastomosis. So based on anatomical effects. So one is called as jejunocolic resection. So what do you mean by jejunocolic resection? So what are things you resect? So here, jejunocolic anastomosis we're talking about. So what are the resection that's happening here? So because you are anastomosing jejunum and colon, so here the entire ileum has been resected. Here the ileocecal valve has been resected, and you have resected a part of colon, and in fact some amount of jejunum is also resected. Some jejunum will be resected. Entire ileum and some jejunum is gone. So which means this is jejunocolic anastomosis. This is the most common anatomy. Overall, if you see, this is the most common anatomy in patients with short bowel syndrome. Here the prognosis is variable. Prognosis depends on the remaining length of the jejunum. The remaining length of jejunum is good enough to take care of the nutrients, then it's fine. The remaining length of jejunum is poor. If very less, then it's a problematic thing. So then we have something called jejuno-ileocolic anastomosis. Jejuno-ileocolic anastomosis. Here, what are the things that are resected? Here, you have resected a part of ileum where you have retained the ileocolic valve and the entire colon has been resected. No, ileocolic. Only the part of ileum has been resected here. Only part of ileum has been resected here. So what are things that are remaining? Jejunum is remaining. Part of ileum is remaining. Then ileocecal valve is also remaining. It's there. And entire colon is there. So which means most of the portions of intestine is left. Only a part of ileum is resected here. That's why it's called a jejuno-ileocolic. So here you have the best prognosis overall, which means here the resected segment is quite less. Only a part of ileum is resected. So it has something called as a best prognosis. Remember, having a residual ileum is very, very advantageous. Why having residual ileum is very advantageous? Because it prevents B12 deficiency. It prevents bile acid malabsorption, because bile acids and B12 are typically absorbed in the distal ileum. And fluid absorption typically happens more in the ileum. So there will be less electrolyte and water loss in this situation. And ileum is the one that produces maximal intestinal adaptation. So in the sense like when you remove ileum, jejunum cannot adapt. But when you remove jejunum, ileum can adapt. So ileum is the one that produces maximal intestinal adaptation. So that is the reason why when you leave a part of ileum, it has a good advantage. So that is the reason why it is supposed to have something called as a best prognosis. But what is the treatment? Treatment-wise, it's very difficult. Let us see the clinical features first. What will be the clinical features? Clinical features-wise, many of these children or adults will have features of malabsorption, depending on how much amount of intestine that is removed. Then there will be gastric hypersecretion to compensate for the lost intestine. The gastric cells will be trying to produce hypersecretion. So this will result in more incidence of peptic ulcer disease. Third part is third part we have not discussed. Okay, third part is something we have not discussed. That is called end jejunostomy. Sorry. Thank you, Ankit, for asking that. Third part is end jejunostomy. End jejunostomy. So end jejunostomy means you have lost ileum, you have lost colon, you have lost everything. Only jejunum is left. That too, a part of jejunum is left. This is the one that is supposed to have a worst prognosis of all. That is end jejunostomy. So three types I told you. So one is jejunocolic, next is jejuno-ileocolic, third is end jejunostomy. Jejuno-ileocolic is the one that has the best prognosis. Jejunocolic is the most common type, intermediate prognosis, and end jejunostomy is the least common type but has the worst prognosis overall. Because you have removed the entire ileum and you have removed the entire colon. As I told you, retaining at least a part of ileum has numerous good implications. In the sense, like if you retain a part of ileum, you produce intestinal adaptation. Number one, that is very, very important. Second, fluid and electrolyte loss will be much, much lesser. Third, B12 deficiency will be very less, and bile acid malabsorption will not happen. So these are the 4 important implications. So that is the reason why retaining ileum is important. So, I mean, it's not like the surgeon willingly cuts the ileum. It's like sometimes situation to save the life, you need to cut the ileum. Because if it's necrosed, if it is completely damaged, perforated, long segment strictures, what you can do about it? You need to resect that part. So if at all you are able to retain the ileum, that is really good. If you're not able to retain the ileum, it has little bit of poor implications. But angiogenostomy is the worst prognosis overall. And the 2 important clinical features will be classic malabsorption features will be there, like severe diarrhea. In fact, they will have weight loss, failure to thrive in infants, severe diarrhea, steatoria, oxalate stones, cholesterol stones, depending on again ileal resection is there or not. Malabsorption is very, very important. And second is something we called as gastric hypersecretion. Gastric hypersecretion, that is because to compensate for the ileal loss. I mean, we compensate for the small intestinal loss, stomach will start secreting more. So they can result in what is that? Peptic ulcer disease. At the same time, this can have bad implication because when you have a gastric hypersecretion, the pH will become acidic. So remember, already, like intestines are not functioning properly because of short bowel. When you have too much of acid hypersecretion, if it produces acidic environment, that prevents the pancreatic enzymes from working normally. Because for the pancreatic enzymes to work normally, you need an alkaline environment. So this acid hypersecretion can further result in reduced function of the pancreatic enzymes that can actually worsen the malabsorption. That's why these are 2 important things. So that's why acid suppression is very, very important treatment of short bowel syndrome patients. So what about the treatment? Treatment is extremely difficult. So basically you have 2 types of phases. One is called as acute phase and second is called as adaptation phase, where the other part of the intestine tries to adapt. So acute phase is the one that starts immediately, usually lasts for 3 to 4 weeks post-resection. So in the first 3 to 4 weeks post-resection, we will be in the acute phase typically. Adaptation takes around 1 to 2 years to happen. So usually during the acute phase, there will be, like high volume losses in the stools, fluids, electrolytes, and there will be a lot of metabolic derangements. And the most common, most often the patients die during this phase only, acute phase. Death is very common during this situation. High volume losses, and it will be accompanied by a lot of metabolic derangements. But during adaptation phase, slowly, the things will improve. Improvement will happen. In the sense, like intestinal transit will be a little slow. The structural and functional changes will happen. So nutrient absorption will increase. The villus will increase. So they will start slowly adapting. And again, adaptation is maximum with ileum only. So ileum is resected means adaptation will be poor. If ileum is not resected, at least a part of ileum is left means adaptation will be extremely good. So improvement in all these things will happen over a period of 1 to 2 years. So as far as the treatment is concerned, especially during the acute phase, the fluid and electrolyte management is very, very important because there will be high volume losses. The patient will be going for severe fluid and electrolyte depletion. So you need to replace all these fluids and electrolytes, which are very, very important. And you might be needing a TPN, total parenteral nutrition, because if you give more and more through the intestinal route, the more they are going to lose, and more osmotic effect and sometimes can worsen the issue. So you might be needing to consider a total parenteral nutrition also. So later on, once the things improve, then you can slowly transit to enteral nutrition. Once the stool volume is controlled and stool volumes are reduced, then you can probably go for enteral nutrition. But if the stool volumes are very high, means there is no other option. You have to go for total parenteral nutrition only. As I told you, acid suppression is very, very important, which worsen the malabsorption. At least for 3 to 12 months till the adaptation starts, you need to give acid suppression. You need to give PPIs, and you have to give anti-motility drugs. Anti-motility drugs, especially drugs like loperamide, codeine. So you might be needing to give because the intestinal motility transit will be very fast because you have a very short segment of the bowel. The food takes a very short time from coming from proximal part of the intestine, distal part of the intestine if you have a very short bowel. So to reduce the motility, you need to give some anti-motility agents like loperamide or codeine. And apart from that, you have some special drugs. Suppose if you have extra adjunctive drugs, is something that is very, very important. And there are some questions from this. Suppose if continuously you have high volume losses, which means your amount of stool production is extremely high, despite your best efforts, then you can try octreotide or clonidine. So if the patient is unable to wean from TPN, which means still you are having high losses, then you can use GLP-2 analogs. So typically the drug that is called as teduglutide. Remember, this is not a diabetic drug. There is something called GLP-1 analogs that we use for diabetes and weight loss. Liraglutide, albiglutide, exenatide, lixisenatide. So these are GLP-1 analogs. But what we use for short bowel syndrome is GLP-2 analogs, not GLP-1 analogs. The classic drug that we use is teduglutide, which is basically going to reduce intestinal motility, but it has no anti-diabetic action. It works only on the intestine. Reduce intestinal motility. Because of that, you might have some benefit in patients with short bowel syndrome. So GLP-1 analogs are incretin-related drugs. Incretin effect works in diabetes, also produce reduced intestinal motility and weight loss. But GLP-2 analogs are not incretin drugs. They don't have any diabetic action, and they reduce only intestinal motility in patients, especially useful in patients who are having short bowel syndrome. And typically, the final stage will be surgery, last resort, but generally none of the surgeries are proven to be effective. But theoretically speaking, the only thing that is best is intestinal transplantation, but it itself has a lot of complications. After transplantation itself, you can get a lot of strictures, but in relentlessly suffering patients, what else you can do? So this is the theoretical best. Indications for doing intestinal transplantation in patients who are theoretically going to have a lifelong TPN dependence. So which means you cannot wean from TPN at all, and they are supposed to have a lifelong TPN. And if they develop TPN related complications, for example, liver failure is one of the TPN related complications. Recurrent venous thromboembolism is a TPN related complication. The catheter related sepsis is a TPN complication. So in patients who cannot be continued with TPN, and in patients who are having lifelong TPN dependence, only theoretical best option is intestinal transplantation. And there are some intestinal lengthening procedures which will be discussed better in surgery. There are many procedures are there. So one is called as LILT, that is called longitudinal intestinal lengthening procedure and tailoring procedure. And next one is called a STEP procedure. That is called a serial transverse enteroplasty. So each and everything has some definitive steps and definitive mechanisms of how they act. So remember, lengthening procedures may be working better in children, maybe, but it will not work in adults. Transplantation may be the better option in adults, not in children. So children, if you want to do a surgery, you can prefer lengthening procedures. In adults, you can prefer probably intestinal transplantation. But nevertheless, both are only experimental. Right now, very limited centers do that, and it's very difficult to do and not an easy job at all. And the patient is going to suffer a lot. The quality of life is going to be extremely, extremely poor in this situation. So two procedures, LILT. One is called intestinal, longitudinal intestinal lengthening and tailoring procedure. And second is STEP, that is called a serious transverse enteroplasty. So that's called STEP. LILT is longitudinal intestinal lengthening and tailoring, and STEP is serial transverse enteroplasty. So lengthening procedures in children and intestinal transplant in adults is the usual thing, but very, very rare. We don't do. So when you do intestinal transplant, whenever the patient is having lifelong TPN dependence, plus they develop irreversible TPN complications, liver failure, catheter thrombosis, or catheter-related sepsis. So where you cannot continue the TPN, in that scenario, you have to go for intestinal transplantation. But nevertheless, this is a very difficult disease to treat and not a desirable disease. It's going to affect the quality of life very badly. So as far as short bowel syndrome is concerned, what are the questions they are going to ask? If at all they ask questions, they might be asking you the causes of short bowel syndrome. Next thing, they might be asking you the anatomy, which is the best prognosis, which is the worst prognosis, and what are the important advantages of having an ileum, and what is the most common type. So that is something that might be asked, and they might ask you the definitions of short bowel syndrome. The numbers are not important, it's more subjective, but still they might ask you the definitions. As far as this thing is concerned, how gastric hypersecretion affects the malabsorption more in patients with short bowel syndrome is something that you need to know. And apart from that, what is the treatment and what are the drugs? Especially GLP-2 analogs are the ones that are very commonly asked in exam. So if they give teduglutide, go for short bowel syndrome. If they ask you GLP-2 analog that is used in short bowel syndrome, answer will be teduglutide. In either way, they might ask, and some lengthening procedures are there which you might consider. And when you do surgery, when you are going to do surgery in patients who are going to have lifelong TPN dependence and they have developed TPN related complications like liver failure or sepsis. So these are the indications for doing intestinal transplantation. But it's only theoretical best, but practically we have not achieved the like desirable results till now. So I think with this we'll close down the discussion for now. And in the next session, we are going to discuss on IBD and probably colonic cancer. IBS, IBD, colonic cancer is something which I'm going to discuss in the next session. Right now, we'll finish this off and let us go sleep. Thank you very much. Good night. Yeah, bye-bye. This will be uploaded tomorrow. I'll ask them to upload this session tomorrow.